There is no conflict of interest and no financial disclosure in this. I'll be presenting on corneal involvement among COVID-19, Rhino-Orbito-Cerebral Mucormycosis, and the treatment. So let us start with the introduction, which says that as we all know, the second wave of COVID-19 pandemic has led to a high resurgence of mucormycosis. More than 47,000 cases of mucormycosis were reported in 3 months from India itself, between April to June 2021. The fatality rate of cases reported from India was less than that which were reported globally, probably because of the predominance of Rhino-Orbital mucormycosis. So during the first wave of COVID-19, India contributed to approximately 71% of the global cases of mucormycosis in patients with COVID-19 from December 2019 to the start of April 2021. The reported mortality obtained from review of literature from India says it was much lower than the previous Indian data on known COVID-19 mucormycosis. The crisis of COVID-associated mucormycosis, it was further worsened because there was a high load of patients, and again, there was an acute scarcity of amphotericin B, which was caused by a large number of cases of mucormycosis. The organism which was responsible for this was primarily Rhizopus, which was followed by other species of Rhizopus. Rhino-orbital and Rhino-Orbital-Cerebral Mucormycosis were the most frequently seen presentations of COVID-associated mucormycosis, which had accounted for 89% of cases in India, while globally they accounted for only 64%. The risk factors pre-COVID-19 era, it was diabetes mellitus and the hematological malignancies and organ transplant recipients. In post-COVID-19, because of, again, injudicious use of steroids, it had led to uncontrolled diabetes, neutropenia, hematological malignancies, any organ transplantation trauma. This would have been a surgical trauma or a physical trauma or a burn. And use of immunosuppressants were the common risk factors post-COVID-19. So as we all know that the spores of mucormycosis, they are inhaled through the nasal mucosa, they go to the alveoli, and in the alveoli, these spores are inoculated, they inoculate into the alveoli. The second pathophysiology which we know is either the surgical trauma or any kind of trauma which led to the penetration of these spores into the skin. Then what happens is macrophages and neutrophils, they try to phagocytize these conidias. But if a patient is already immunosuppressant, if a patient is on glucocorticoids, if he has a very low immunity, this particular phase is the macrophages, and the neutrophils, they are not able to phagocytose this conidia. Then what happens is these conidia, then they again proliferate into hyphae. Again, I would like to emphasize on the free iron, which is available in the body, which is responsible for multiplications of hyphae. So this furoxamine is also a cause wherein we can see the proliferation of hyphae. And all this, if a patient, again, on why we are emphasizing on glucocorticoids in diabetes, because all these important factors in limiting the proliferation of hyphae are prohibited by if a patient is taking glucocorticoids or if a patient is diabetic or an immunosuppressant. So at the end, what happens is when there are hyphae, they go to the bloodstream, they go to the vessels, causing the angio invasion, and then they go to the different end organs. The established risk factors which were there, as you already know, is the uncontrolled diabetes mellitus, immunosuppressants, and the availability of free iron. The pathophysiology is if there's a phagocytic dysfunction, angio invasion, there's a hematogenous spread, as well as there's a contiguous or a local spread to the organs. Then the treatment for mucormycosis, as you all know, the lipid formulations of amphotericin B are favored. Why? Because the deoxycholate form of the amphotericin B, if it is needed in such a huge amount, is nephrotoxic. So the best preparation is the liposomal amphotericin B, because we have to give it in high daily doses, and that has to be continued for like, depending on the severity of the disease, it might continue up to 3 months. And with amphotericin B, there are few alternatives of azoles, isobuconazole and posaconazoles. So I would like to start the materials and methods of my study. It was a randomized, observational, record-based 32 patients of total 20 patients who were admitted, and 32 patients had shown corneal involvement. The inclusion criteria were the confirmed cases of invasive mucormycosis. The confirmation was done on diagnostic nasal endoscopy, which came out to be positive on 10% KOH, and radiological plus clinical features. Second, the invasive mucormycosis patients with corneal manifestations, invasive mucormycosis patients with ocular surface manifestations, and patients with ocular coat involvement. The parameters which were recorded on the proforma, it was a torchlight examination because most of them, they were not ambulatory, they were really sick. And the investigations and the examinations were done only on bedside. So the visual acuity, pupillary reactions, extraocular movements, facial symmetry, orbital signs, and the Schirmer test. These were the tests done. The corneal ulcer, which is the main focus of this presentation, was noted at the size of the ulcer, the site, the shape, the extent, the infiltration, the satellite lesions, corneal sensations, the anterior chamber status, the IOP, digital IOP, and the fundus. Then there's a special staining which we do just to know the corneal health. There could be diffuse, so it was divided into diffuse staining, punctate staining, whether there's a central or inferior staining, or whether there are filaments present. So corneal scraping was done whenever it was feasible. The conjunctival swab was sent. The pus, if there was a pus in the conjunctival sac or from the surroundings, it was sent for the KOH and gram staining. The overall treatment broadly, which we gave, was the systemic liposomal amphotericin B, because they were all invasive ROCM cases. Oral posaconazole if a patient was allergic to amphotericin, or if was showing side effects or complications to amphotericin B. The topical amphotericin B we used because there was a corneal involvement, the ocular involvement, so it was diluted to a level to make it to 0.5 mg per 1 ml. So it was a 50 mg per ml powder solution, which was then diluted to 5% dextrose, making it to 0.5 mg per ml. Accordingly, depending on the other ocular features, we used lubricants, anti-glaucoma, and cycloplagics. The result of my study was the primary outcome was taken as a time for epithelialization, to decrease in the ulcer size, decrease in the infiltrate extent and depth. So again, on torchlight, it was seen as if there's a clarity of the media or clarity in visualization of the interior segment details. The secondary outcomes were whether there was a symptomatic relief to the patient, as symptoms, they begin to resolve prior to the improvement in the objective clinical appearance. Visual acuity was not taken as it is not feasible. The mean age group was 52 plus minus 12.8 years. There were 22 males in my study with 10 females. The associated risk factors, as I've already discussed, was uncontrolled diabetes, recent COVID-19 infection, injudicious use of systemic steroids. So out of 32 patients, 29 patients were non-diabetics, 32 had recent COVID-19 infection, and 13 gave a history of injudicious use of steroids. The right eye was affected in 9 patients, left eye in 20, and both eyes were affected in 3 patients. So this is how all my patients presented. So these, the patients, they had presented to us with corneal melt, corneal ulcer, diffuse corneal punctate staining, and I'll be showing the pictures later on in my slide, and scleral perforation with Desmond fold. So why I have distributed it like this? Because I have to mention the ocular signs and symptoms, then the other signs, which were orbital signs, like the patients who were having the involvement of cavernous sinus, or if there was involvement of multiple nerves, ocular nerves, then most of my patients, they had presented with ptosis and complete ophthalmoplegia. So that is again, we can say, because they were all categorized in invasive Rhino-Orbito-Cerebral Mucormycosis, stage 3 to 4. So broadly, I'll be telling that most of my patients, they received systemic amphotericin B. Just a few of them had complications, so we had given them posaconazole. And the outcome I'll be discussing later on. So the another entity which was seen in my patients was there was just one patient which is presented with filamentary keratitis. That is because he had a very, very severe dry eye. There was another patient who had a limbal ischemia with corneal haze. Another one, a diffuse stromal abscess. It was limbus to limbus stromal abscess was present. There was one patient who had presented with diffuse scleritis with corneal punctate staining. Another presentation of my patients was a conjunctival cirrhosis, that is conjunctival dryness, with inferior corneal exposure keratopathy. There was one patient who presented to us with a perforated corneal ulcer. But he later on with the treatment healed and the eye went into phthisis. So this is the overall, which I would like to just tell out of 32 patients, 9 had corneal ulcer, 6 had presented with diffuse corneal punctate staining, and 3 had corneal melt. Rest all were showing different kinds of presentations. So this is, I'll be explaining here, this is how they had presented. Some of them, few of them were taken on slit lamp, and most of them, they are just the torchlight examination. So here we can see there's a diffuse congestion with swelling. So this was a patient of mucormycosis showing the central corneal ulcer with obviously diffuse scleritis. So this is the patient where there was as we can see, there is a hyperpigmented area which showed a very spontaneous, probably limbal or scleral perforation leading to anterior chamber collapse with formation of these DM folds. Another patient is this is the special staining which I was talking about, and seen under a special light, and it is done under a slit lamp. So this green thing shows that the patient had a perforation of the corneal ulcer leading to the this type of staining. So this was another young patient who had presented to us with the corneal haze and anterior uveitis leading to synechial formation, and cataract was forming in this patient. This is another patient with a central large corneal ulcer. This green thing shows that there was a large corneal ulcer. This is another patient showing a diffuse limbal ischemia with scleral abscess, limbus to limbus, corneal abscess, and a diffuse limbal ischemia with scleral abscess. Another patient, again, this was because of exposure. He had a lagophthalmos leading to inferior diffuse punctate staining with the central big corneal ulcer. This was another patient who had presented with, again, limbal ischemia, scleritis, and corneal abscess. And these pictures are showing once we have treated them, depending on what the disease was. So this shows that after healing, the congestion is gone and there is just the formation of corneal opacity at the inferior part of the cornea. And this picture shows, so here it was all making DM folds, and the AC was collapsed. After treatment, there was a sealing of this perforation leading to anterior chamber formation and better visualization of anterior chamber and the structures beyond the anterior chamber. This is again, so here we can see that the staining has gone little less if we compare it from the pre-treatment photo. This picture is again, the corneal haze stays the same, but since there was anterior uveitis, which was the inflammation of the anterior chamber leading to formation of a complicated cataract. This is again the large central corneal ulcer. It had then regressed to the inferior staining leading to the the size of the ulcer has reduced after treatment. This is the patient who had shown a central corneal ulcer with the exposure keratopathy. This patient first resolved and then he again developed the similar central corneal ulcer. In this patient, because of a diffuse large corneal ulcer, we have to do a tarsorrhaphy so that we can prevent further exposure of the cornea and further melting of the cornea. So in the results, as I've discussed, there were 20, the left eyes were affected more in my patient. The 6 of my patient, they expired because of, again, the cerebral involvement and the comorbidities, because most of them, they were immunosuppressed. They were having some chronic kidney diseases due to uncontrolled diabetes. So, and 6 of my patient, they had undergone exenteration because in spite of corneal treatment, the disease was there in the orbit and is progressing to the beyond the orbit. 10 of my patients, they got healed. 1 developed complicated cataract, but there was a healing of corneal manifestation. 3 symptomatically and clinically improved. And there was 1 patient who did not show any response to the treatment. There was 1 which was the last picture which I had showed. It had healed with the topical amphotericin and tarsorrhaphy. And 1 who had a corneal stromal abscess, he needed an intrastromal amphotericin B. There were 2 patients who had shown recurrence once they were healed. And again, another 1, he was symptomatic, spontaneously healed. He healed without any treatment given. So that is all in my presentation, and I would like to thank you for listening to me so attentively.
To all, ladies and gentlemen. Hi, I'm Anne Shafira from Department of Basic Sciences, Physiology, Faculty of Health Sciences, UITM. And today we would like to share with all of you our research titled Two-Dimensional Gel Electrophoresis Analysis on the protein plasma, differences in the progression of diabetes. So as an introduction, we know that the prevalence of diabetes is very high and it has increased about 51% compared to the previous one, which is on in 2019. And it has been projected to be becoming 700 million people are going to live with diabetes later. So if we look into this 8 regions that have been classified or clustered by the IDF, I would like to focus on the highest number, which is at the Western Pacific, which the projection would be 260 million people in the Western Pacific is going to have the diabetes. So why Western Pacific? Is because Malaysia is located in this region. So 1 in 3 of the adults at risk of developing type 2 diabetes live in Western Pacific region. And if we focus on Malaysia itself, the prevalence of diabetes among Malaysian adults also increased from 11.2% in 2011 to 18.3% in 2019. So when we talk about pre-diabetes, we know that about 15, the statistical report showed us about 15 to 30% of people who live with a pre-diabetic prone to convert to become full-blown of type 2 diabetes in 5 years' time if they are not being treated or if they are living with the same lifestyle. So this is because the dysglycemia that they are happening at the pre-diabetic level is actually the initiation of the process damaging in the human body. Because why? Because there are the incidence of the endothelial damage happen, the inflammation also happen at these levels. So and the condition is actually showing the early pathological condition toward type 2 diabetes and also the complication. So this is a sequence, as everybody knows, the development of the type 2 diabetes started with the insulin resistance, and then we got the impact glucose tolerance, and they were start the beta cells failure before it progressed to the type 2 diabetes. So the hyperinsulinemia is actually the process where the pre-diabetics is happening. So our objective, ladies and gentlemen, is to map out these changes by identifying the spectrum of the protein alteration involved in the molecular and also the structural pathogenesis. So when we have the dysglycemia, we know that the endothelial dysfunctions happen, inflammatory is happening in the system, and where there is actually the early complication before it convert to the full-blown of type 2 diabetes. So let us now move to the method that we have done, which we started with the sample prep, and then until the 9th step, which is the protein characterization, we are actually using the LCMS. So this is a cross-sectional study. Usually when we do a sample prep, we do the education setting to the community, explaining about not just diabetes, but the main concerns is on the pre-diabetes before we start collecting the samples, and we are focusing on the plasma. So as our concern is to look into the low abundance protein, so that is why we need a step to deplete the high abundant protein using the HU6. Why HU6? Because we are trying to remove the first 6 high abundance, which are IgG, IgA, transferrin, albumin, haptoglobin, and also antitrypsin. So when we got the low abundant protein, because it is a very little, we need to be concentrate. It must be in a concentrated form. So that is why we have this tab to concentrate the low abundant protein that we got, and we have to dissolve the sample. And then only we do the protein quantification using a Bradford assay. And before we begin, which is the main step in this research, using a 2-dimensional electrophoresis. So this 2DE involve 5 steps, which is starting with the sample prep and rehydration. We have 2 separation of protein, which is the first dimension and also second dimension, before we do the staining. So I just would like to highlight here the principles of the technique, which is the 2DE, which they are focusing on the separation based on the first step is their isoelectric point. And then after that, we are using the pH 310, 13 cm stripe. And then only we do the second dimension separation. And this part is using the molecular weight. So this is how we conducted in lab the first step. And then this is after we completed the first step, we do the IPG strap equilibration for 1 hour before we proceed with the second separation of the protein using based on their molecular weight for 5 hours. And this is how it's look alike. And we can see our Hofer SC600, they are band here. So once after the 5 hours, the bands will come down, showing that all the separation have completed. So after that, we do the gel staining, and then this is how how the gel is look alike after we stain. You can see a lot of spot here, a lot of spot, where actually we are just looking on the low abundant protein. This is the control where you see the whole protein, and if you can see the middle one is the albumin, the highest number of the protein in the system. Then only the final step, we do the image acquisition and also the analysis. all right? So this is a step where we try to pick the protein before we do the analysis using the protein identification, LCMS, MS. Right, so let us now move to the final part, which the result and discussion. I would like to show you, this is the control group where we have a crude human plasma with high and also the low abundant protein. So when we do the separation, we try to remove the high abundant protein that masking the plasma. All right, so the yellow one is high abundant protein. So the blue color is the one that we are focusing on. All right, so this is a samples from the early diabetes patient, the blue color, and then the purple, the pink one is for from the pre-diabetes group. So from here, we can see that there are significant spot when we compare between the pre and also the early diabetes group, which is showing clearly significant difference at the SSP 3301 and also the SSP 5301. When we compare the pre-diabetes and also the established group, we can see two spots are upregulated and one spots are downregulated. And finally, when we look into the early diabetes and also the established diabetes, two spots are downregulated and one, which is SSP 6606, are upregulated. So from there, we try to map out on the canonical pathway to see what is a significant pathway involved. So it is highlighted here. There are three, which is the LXR activation, FXR activation pathway, and also the acute phase response signaling across the three groups. So this is the protein that have been mapped out in the LXR activation pathway and also FXR activation pathway. We know that FXR and also LSR receptor are metabolic regulator that play an important role in the pathogenesis of type 2 diabetes, and it is exert a complex character in transcriptional regulation of the genes involved in the pancreatic beta function, the lipids, and also the carbohydrate metabolism. So this is the third one have been mapped out, which are the acute phase response signaling pathway. So we know that the acute phase response is a rapid inflammatory response that provides a protection against microorganism using non-specific defense mechanism. Beside them, increase in protein in the plasma levels, indicating a chronic subclinical inflammation, including the one that we're focusing, which is on the type 2 diabetes. So as a conclusion, the protein that have been identified as expressed may play a role in development of type 2 diabetes and also the complication. So additional research focus on the pre-diabetic group is imperative to evaluate the issue's severity and provide future preventive and also the therapeutic intervention. So how are we going to prevent type 2 diabetes? So we always talk to our the community, to our patient, that it is recommended to reduce the weight about not much. It's just about 5 to 7% of your body weight. How are you going to do that? To reverse your pre-diabetes, at least a regular physical activity. 150 minutes a week, and if you divide across the 7 days that we have in a week, it's just about 30 minutes a day, right? And why it is important? Because we have to take care of our body, because this is the only place that we have to live with, right? So this is my team members from Monash University. With that, I thank you.
Thank you so
Today, I would like to talk about diabetes. Topic given to me is to evaluate the levels of glycated serum calcium, magnesium, phosphate, uric acid, and microalbuminuria in patients newly diagnosed type 2 diabetes mellitus.
Dr. Prabhas, could you please mute yourself?
So, diabetes mellitus has more than doubled in global prevalence over the last 3 decades, making it one of the most serious public health issues confronting all over the country. The root of the diabetes epidemic are rooted in a complex network of genetic and epigenetic system that interacts with a socio-cultural framework that shapes behavior and influences environmental factors. It has been predicted that the countries with the largest number of people with diabetes mellitus will be from India, China, and United States in 2025. Patients with type 2 diabetes mellitus are a high-risk group and metabolic disorder contribute to the prediction of morbidity and mortality in this population. Metabolic disturbances include change in serum calcium, magnesium, and phosphate can explain why dyslipidemia, hyperglycemia, and hyperuricemia, which are related to obesity, impact the progression of type 2 diabetes mellitus. Now, the aim of our study was to see and compare the HbA1c levels, calcium, magnesium, and phosphate, uric acid, and microalbuminuria in patients with newly diagnosed type 2 diabetes mellitus with normally healthy individuals. So, this cross-sectional study was done in Department of Biochemistry in SKIMS Medical College, Srinagar, India. Total 300 subjects were included in the study and divided into 2 groups. Group 1 included normally healthy individuals and where they were from the age of 30 to 80 years of either sex. Group 2 included 150 newly diagnosed type 2 diabetes mellitus patients with the same age group. Informed and written consent was taken from all the subjects who were included in the study. Inclusion criteria: patient suffering from newly diagnosed type 2 diabetes mellitus. Exclusion criteria include patients suffering from acute complication of diabetes mellitus, those with history of acute infections and other ailments like gross congestive heart failure, tuberculosis, gout, rheumatoid arthritis, skeletal muscle, and renal failure, and those who were on hypoglycemic drugs or insulin were excluded. Fasting blood sample were drawn and investigated for these parameters on Beckman-Coulter AU42400. 24-hour urine was taken for estimation for microalbuminuria by immunoturbidimetric method, and these values were compared with those of normal healthy individuals. Data was used and compiled using SPSS software, and statistical significance was given less than 0.05. Our results showed that the mean age of cases and controls were 55 years, which included 92 males and 58 females. And cases we have 55 plus minus 12.92 with 89 males and 61 females. Maximum number of patients were in the age group of 41 to 50. That means 40% of the patients were in this age group. So these are the results what we got. We had a significant difference in fasting blood glucose level, HbA1c, then calcium. We had calcium, we had low levels in cases as compared to controls. We had low magnesium levels, we had low phosphate levels, we had high uric acid levels, and high microalbuminuria levels in urine in cases as compared to controls. In the present study, it was observed that the fasting levels of cases were significantly higher than their controls. In our study, HbA1c level of controls is 4.6%, and in diabetes, it was 8.9%. HbA1c levels are significantly raised in newly type 2 diabetes when compared with controls. Several studies report that there is a positive correlation between HbA1c and the duration of diabetes mellitus, and a strong predictor of risk factor for diabetic complications. Use of glycated hemoglobin can play a major role in case finding in hospitalized patients with random hyperglycemia, and it does not require fasting necessity, fewer blood drawn, unaffected by recent food intake or recent change in blood sugar levels. Our study showed lower levels of serum calcium in cases as compared to controls. Previous study also suggests that altered calcium homeostasis may play a role in development of type 2 diabetes mellitus, as calcium intake is inversely associated with development of type 2 diabetes mellitus. Also, intake of calcium supplements were associated with low risk of type 2 diabetes mellitus. In this study, there was a low levels of calcium and magnesium levels in diabetic cases. This can be possible explained by as diet low in magnesium osmotic diuresis causes high renal excretion of magnesium, insensitivity to insulin affecting intracellular magnesium transport, and thereby causing increased loss of extracellular magnesium and reduced tubular reabsorption due to insulin resistance. Dietzel founded that maximal capacity of renal tubular reabsorption of phosphate were significantly suppressed in diabetic patients, and also reported that urinary phosphate excretion was 3 times higher in diabetes patients when compared to healthy individuals. This is in concordance with our study showing low phosphate levels as compared to cases, normal individuals. Then other study which shows that hyperuricemia has been associated with insulin resistance and is an independent predictor of incidence of type 2 diabetes in general population. One of the possible cause is the defect in urate transport, which is responsible for urate reabsorption from kidney, leading to increased uric acid levels in diabetes mellitus. This is in concordance with our study. Microalbuminuria being a well-known early predictor of diabetic nephropathy, and it is due to increased vascular permeability as well as endothelial dysfunction. In our study, microalbuminuria was seen in diabetic cases and was statistically significant as compared to the non-diabetic controls. Now the conclusion. This study suggests that there is a decrease in serum calcium, magnesium, and phosphate levels. All this plays an important role in the regulation of glucose level in the blood. Also, concentration of these were inversely associated with diabetic microvascular complications. Hence, oral supplementation of these ions other than diet is recommended in type 2 diabetes mellitus and may reduce the risk of diabetic microvascular complications. Increased serum uric acid and microalbuminuria was seen with reduced glucose tolerance. Hence, early estimation of both the parameters should be done while monitoring these type 2 cases of type 2 diabetes mellitus, and thus will help to decrease the incidence of renal complications in these patients. Also, physicians should measure urinary albumin excretion in patients with type 2 diabetes mellitus routinely and be aggressive in treating this modifiable risk factor. That quicker diagnosis of type 2 mellitus with the glycated hemoglobin levels can also translate into an early patient mobilization to diabetic support services, treatment, and even early medication response, which will prevent micro and macro complications associated with this disease. Thank you. Any questions?
In chronic hepatitis B/C patient, our introduction is about vitamin D. Vitamin D is a fat-soluble vitamin that is naturally present in few foods, as fatty fish, species, and eggs and beef liver. Vitamin D is critically important for development and growth and maintenance of healthy skeleton from birth to death. The major function of vitamin D is to maintain calcium homeostasis. First of all, it is start with sun exposure to our skin that form what we call 7-dehydrocholesterol that enter into our blood to be hydroxylated in our liver, and then for another hydroxylation that even in the kidney. Vitamin D deficiency is a major unrecognized health problem. Not only it causes rickets in children and osteomalacia and osteoporosis also in adults, but has long-lasting effects as it has non-skeletal functions and mineral homeostasis in kidneys and pancreas and the macrophage and affect our immunity. Chronic vitamin D deficiency have a serious adverse effect, including increased risk of hypertension, multiple sclerosis, cancer of the colon, prostate, breast, and ovary, and also have an effect on insulin secretion and may cause type 2 diabetes. This needs to have a better appreciation for importance of vitamin D for overall health and well-being. Assessment criteria for vitamin D deficiency: if the patient level serum 25 hydroxy vitamin D is above 30, it's called vitamin D sufficient. But if between 20 and 30 nanogram per milli, it's called sufficient. And if below 20, it's called insufficient. Less than 20, it's called deficient. Risk factor for vitamin D deficiencies: first of all, we see all exclusive breastfed infants, and so the American Academy of Pediatrics recommends all breastfed infants should have given a vitamin D supplement since birth by 400 international units per day till first year end. And also the dark skin people sensitize less vitamin D on exposure to sunlight, aging, and less exposure also to ultraviolet radiation. Fat malabsorption syndrome, cystic fibrosis, or polycystic liver disease may impair the absorption of dietary vitamin D. Obesity also increases the risk of vitamin D deficiency, covering all exposed skin, nephrotic syndrome, and also some drugs as anticonvulsant therapy and the patient with liver cirrhosis. Vitamin D deficiency is highly prevalent in chronic liver disease. Intervention study report improvement of chronic liver disease following supplementation. Its mechanism is about reduced exogenous exposure to sunlight or dietary in patient of hepatic or intestinal malabsorption due to congestion, reduce the endogenous production of vitamin D binding of albumin, which help to absorb vitamin D, impair the hepatic hydroxylation of vitamin D, and finally increase the catabolic removal of vitamin D. So we did our study in on this condition with the aim to assess relation between vitamin D and the chronic hepatitis C regarding 90 patients by cross-sectional case-controlled study recruited from our outpatient clinic and ICU patient admitted to internal medicine department at Tanta University Hospital from Egypt. We used what we call the child buff score to assess a liver condition in form of ascites, bilirubin, albumin, BT, prothrombin time, INR, and encephalopathy, and assessing the number of points to class the patient between class A, class B, class C, and to assess his liver dysfunction. We take 30 patients with child score A, 30 patients with child score B, 30 patients with child score C, and 10 subjects of normal health as a control group for this study. Our inclusion criteria of all patients of chronic hepatitis C with normal kidney function. Our exclusion criteria is pre-existing renal impairment or patient who had used vitamin D supplement during the last 3 months. All patients included in this study were subjected to full history taking, full clinical examination, laboratory investigation in form of vitamin D by ELISA kit, and a written consent. Our results show that as regarding demographic data of age and sex, all 4 groups has no statistically non-significant results. But about laboratory study, the all patient regarding serum albumin, bilirubin, liver function, and prothrombin time and activity, Serum albumin and bilirubin show significant between in different child scores, and the prothrombin time also show different significant between both. As regarding vitamin D, the vitamin D level was significantly decreased as a child classification increasing from A to C. Child A is mild liver dysfunction, the range between 23 and 53. Patient with moderate liver dysfunction. Child B is between 22 and 30. Patient with child C show significant reduction 1.9 to 31, and the control group was from 30 to 40. It also shows that a child A has a higher level of vitamin D than a child B, than a child C, and all liver dysfunction show lower level of vitamin D than control group, which was normal people. We also used another parameter for liver dysfunction, which we called FIF4. It's include parameters of age, AST, platelet count, and ALT. And as regarding correlation between vitamin D and the different laboratory parameters, it shows significant decrease in FIF4 score between in correlation between vitamin D and FIF4. Our correlation show negative correlation between bilirubin and vitamin D, but it show positive correlation between vitamin D and albumin in form of p-value 0.001. It show also significant positive correlation between vitamin D and the platelet count, and the negative correlation between vitamin D and the FIF4 score. Our results show vitamin D level was significantly decreased as the child classification increasing from A to C. Also, the vitamin D level in patient with child A was significantly decreased when compared to healthy individual. Our study showed negative correlation, as we said before, between vitamin D and the bilirubin and the FIF4, and also positive correlation between vitamin D and the albumin and the platelet. Our conclusion: vitamin D deficiency is present in patients with chronic liver disease in recurrently recognized beneficial effect of adequate level of vitamin D. Measurement of vitamin D and replacement may be considered as a part of overall management of patients with chronic liver disease. And our finding raises the question whether testing and treating vitamin D may improve liver function and outcome in cirrhotic patients. And it may help us to predict level of fibrosis, as we included in FIF4 score and the child BAF score, and use it as non-invasive marker of liver fibrosis, better than percutaneous liver biopsy, which was used as usual trend, and use vitamin D as a marker of liver fibrosis. Finally, the Endocrine Society and the Clinical Practice Guideline on Evaluation and the Treatment of Vitamin D include a statement that called patient with hepatic failure belonging to patient with high risk of vitamin D deficiency, in whom screening, measurement, and reasonable level below 20 who should be treated with vitamin D supplement. Our recommendation: optimal vitamin D level should be present between 30 and 60 nanogram per millimeter and not exceed 100 nanogram per millimeter. In correlation with severe deficiency as patient with breast or colon cancer, which have another comorbidities, optimal vitamin D level target should be between 40 and 50 nanogram per millimeter. All adults who are vitamin D deficient should be treated with 50,000 international unit of vitamin D per week for 8 weeks, or 6,000 vitamin D2 for 1 week, with maintenance therapy of 2,000 international unit. In obese patient, malabsorption syndrome, patient taking medication affecting vitamin D, we suggest a higher level of dose between 6,000 and 10,000 international units of vitamin D treated per day. Finally, it is important to give it all you have while you have the chance, and never forget to sun exposure. And thank you.
Thank you so much, sir. The presentation stood out exceptional, impressing the audience with
We spent our research and reviews on that. And on the last hours I've listened to all these presentations, and I've got very good knowledge and research of all these doctors. So I've worked on few things, starting from the diabetes, and I have worked each once on the research, and the things are very different in Pakistan. Nowadays, we have suffered a lot of things. As globally, we know that 70% of the people are going to suffer leading to diabetes mellitus problem. And diabetes is a disease, sugar and starch is not properly absorbed. And as I have less time, so we'll start the presentation from a flow chart. And I have collected 30 participants, 40 participants, and 20 are male and 20 are female. And I worked on diet and exercise plan on nutrition plus weeks. Before that, I've set up value of HbA1c test, and I have also taken a group of control of 10 male and female participants. And after 12 weeks implementation of program of a balanced diet and exercise, the posters is get from that participants. Before that, few people are left the study due to their personal problem, and the posters state sample test is used for analysis. And as I've heard, this is all about my research which I have done in the weeks. We started that presentation with demographic variables. I have taken demographic variables of all the participants, and as it's shown in the diagram and in the figure as well. The mean and standardized values along with age, weight, height, and BMI and present. Nutrition. There should be 16 to 11 servings in a day. This is hard and fast, and for extent, the number of servings depend on the diabetes score. Calories, nutrition needs you like, and the food you like to eat. Vegetables, fruits, milk, meat, and meat. 3 to 5 servings for vegetables, 2 to 4 for fruit, and 2 to 3 for milk, 4 to 6 ounces per day. This is a comprehensive plan for 12 weeks, which I have implemented on these participants. And I have done 3 different types of exercises: cardiovascular exercises with intensity 55 to 65, 1 to 2 minutes interval. Keep in mind, blood sugar level should not be dropped in the duration of exercise. This is most important thing while you are working on this thing. The initial time should be 15 to 20 minutes, or it can be increased gradually by increasing the physical fitness of the patients. Walk is the best exercise for diabetes patient. As I have recommended, ballistic walk is getting more better results, as we have got in the previous one, which is also had previous that I mean on diabetic patients. They are working on light walk, but nowadays I am working on brisk walk and cardiovascular resistance and stretching exercise on that. Resistance training. We can do a resistance training with an intensity 55 to 65%, 2 to 3 minutes interval. But keep in mind, sugar level should be not dropped. As I've told you earlier, that we should concentrate on and keep on checking sugar level during the exercise. There is no need to get any sort of pressure, any sort of thing. We can relax and we can take water sips within exercise or after the end of each set. It will also help not to raise your blood pressure and also keep in control the diabetes or sugar level in the body. Few exercises I worked on that: dumbbells, bar training, split training, isometric training, and so on. Note that exercise should be in controlled and light in stretching. Stretching also plays an important role in controlling the sugar in the blood sugar in the body, and it's not leading to devastating effects such as obesity. Stretching exercise is done at the end of the exercise of the warm-up or at the end of session. Each muscle should be hold 8 to 10 seconds. Safety purpose should always keep in mind for a good instructor. Hamstring stretch, glute, groin, calf, pec, bicep, tricep, low back. Selected subjects. I have selected subjects from 3 hospitals and few laboratories, which is available in around my city, which is Mayo Hospital, Services Hospital, and Jinnah Hospital. HbA1c value, as I've told you, we get p-value and post-value. The results are compared, and I have that results, which means that after exercise and diet plan, we have a good result on preparing these 12 weeks implemented training and diet plan program. And at the end, we have got to know that if we are going to adopt such kind of activity, at least 30 minutes a day or with specific 5-hour intervals, we can also get best results of that. And these are my results as the pre-test. This is mean standard deviation value 6.88, 0.36 standard deviation. The difference value is 0.8 and the improvement is 12%. As I've told you, I'm not going to take any sort of more time because 2 or 3 times that due to internet and electrical problem, and I'm not going to take much more time for the participants. Thank you very much for all of you, and thank you very much to Ms. Bhumi for the patience of and waiting for the rest of the things.
Thank you so much, sir. The presentation exceeded the expectations, showing a perfect blend of mucormycosis is also known as black fungus. It is relatively rare but serious fungal infection. It formerly known as zygomatic and also affect people who are immunocompromised because of diabetes mellitus, steroid therapy, increased serum level of iron, neutropenia, cancer, organ transplantation. Mucormycosis are the group of fungi that cause mucormycosis, and they are present in surrounding environment, particularly in soil, and associated with decaying organic materials such as leaves, compost piles, and animal dung. Clinical and experimental study revealed that individuals who lack phagocytic leukocytes or have impaired function of phagocytes are high risk of mucormycosis. Phagocytes are dysfunctional in presence of low pH, hypoglycemia. Fungal growth is promoted by elevated serum iron level. All this factor predispose patient with diabetic ketoacidosis to mucormycosis infection. Mucormycosis is a serial fungal infection that need to be treated with prescription antifungal medicine, usually amphotericin B. It can be given by orally or by veins. Based on the superior safety and efficacy, lipid formulation of amphotericin B has become the standard treatment for mucormycosis. According to the study and experimental data that suggests that amphotericin B drug may interfere with the hepatic cytochrome P450 and may influence the metabolic capacity of liver, confirming the toxic effect of drugs on liver. There are many studies that reveal drug has toxic effect mainly on kidney. But in this study, we'll analyze the toxic effect of amphotericin in both liver and kidney. Methodology. It is a retrospective study and was conducted using a case record of mucormycosis patient and were admitted to Jimmer's Godri Medical College and Hospital, Vadodara. We included the patient who were admitted to hospital from 1st June 2021 to August 31st, 2021. The data related to demographic detail was extracted, such as age, sex, occupation, religion, region, etc. 3 report. Each of liver and renal function test of each patient was extracted. The liver function tests include bilirubin level, uh, alanine transferase, albumin level, albumin globulin ratio. And renal function tests include serum urea level, serum creatinine level, serum sodium and serum potassium level. The report were entered into Excel sheet and analysis was framed. LFT1 and RFT1 was done before the starting of amphotericin B therapy. And LFT2 and RFT2 was done after 1 week of initiating amphotericin B therapy. LFT3 and RFT3 was done after 2 weeks of initiating amphotericin B therapy. A total of 64 patients with the infection of mucormycosis were reviewed. Out of that, 42 were male and 22 were female. 38 residing in a rural area and 26 residing in urban areas. 3 type of infection was reviewed: Rhino-Orbito-Cerebral, which are majority of cases, Rhino-Orbital and Rhino-Cerebral. From the test, we saw that 5 patients, that is approximately 7% of patient had above normal level of SGPT that increased to 13 in LFT2 and then again raised to 20 in LFT3. Means 20 patient had abnormal SGPT level on test 3 after 2 weeks of amphotericin B therapy. Then 22 patient had already abnormal below normal AG ratio that increased to 32 in LFT2 and again stays 32 in LFT3. Albumin level was below normal. LFT1, that is more than 50% patient was already was suffering for hypoalbuminemia before the starting of the amphotericin B therapy. That increased to 42 and 43 in LFT2 and LFT3 respectively. Renal function test. Here we can see that six patient was having above normal serum creatinine level in RFT1 that increased to 20. Means 20 patient had above normal serum creatinine level in renal function test 2, that was 1 week after the therapy, and after 2 weeks of therapy, 22 patient. Serum urea level. 27 patients already were having above normal serum urea level in RFT1 that increased to 47 and that gradually decreased to 43. Means 43 patient out of 64 had abnormal serum urea level after 2 weeks of amphotericin B therapy. Here you can see a patient is having patient is having hyponatremia. 21 patient is having hyponatremia and that goes to 22 after the therapy. It means sodium and potassium levels do not vary much with the amphotericin B therapy. Especially SGPT level were found to be more commonly elevated among male population as compared to female in LFT2 and LFT3. Conclusion, mucormycosis is more common among male because the diabetes is more prevalently is seen in male compared to female, and mucormycosis is also more commonly found among rural area. That might be due to inappropriate hygiene and lack of medical facilities. Amphotericin B drug does have adverse effect on liver and kidney. That was proven by my research. And 3 consecutive tests of RFT and LFT shows liver and kidney dysfunction due to damage induced by the drug. That led to altered level of the factors of the respective test. The study found out that around half of this study participant had albumin level below the normal range. This might be due to hospital admission-related hypoalbuminemia and diabetes-related chronic kidney disease. Few references of my study. Special acknowledgement to Scientex Conferences for providing me such a great opportunity to present my paper over here. Thank you so much. Please feel free to ask any question if you have.
Diabetic retinopathy is a specific diabetes complications, and main risk factors associated with early onset and more repeat progression of diabetic retinopathy are duration of the diabetes, high blood sugar levels, and arterial hypertension. What has happened? The first layering of vessels walls, changes in blood flow, and changes in thrombocytes. Normal capillary not damage will consist on pericyte, basal membrane, and endothelial cells. And then hyperglycemia causes vessels and capillary wall damages with erythrocytes, alteration, zinc, basal membrane. And you can see the vessels walls damages, and after it microaneurysm formation acute. You can see in the picture. The next step is ischemia. Ischemia formation due to functional thrombocytes damage and alteration disorder with vascular occlusions. And on the retina, you can see in ischemia zone. The next step, the ischemia process to increase the level of the VEGF factor, vessel and the growth factor. Death of pericyte and endothelial cells, non-cell empty capillary formation, capillary degeneration, microaneurysm formation, cell inclusion degeneration, blood-brain barrier dysfunction, increasing of vessels wall transaction and leakage through all plasmatic components, and micromolecular edema develop. The next step, different microaneurysms and alteration formation. And one of the step is retinal hemorrhage, pre-retinal hemorrhage, surface-like flames, and deep roundish. And the next step at this microneurus and intraretinal vessels abnormalities. You can see a white yellow exudates focus in deep parts of the neuroepithelium. Cotton wool exudates and venous alteration you can see on the retina. Now we use this classification, and we see black ground, non-proliferative, proliferative, macular edema, and proliferative vitreoretinopathy. What is the treatment? Non-proliferative diabetic retinopathy treatment control glycemia and arterial pressure control. And you see this patient. But the next step, VEGF K regular or normal and pathological angiogenesis. VEGF most important role in the neovascularization, start endothelium cell proliferation, require cell migration, and prevent apoptosis. VEGF and PGF factor main stimulate factor of the retina neovascularization hypoxia. In case of the retina disorders associated with neovascularization, VEGF and PGF level increase and helps pathological vessels formation and inflammation development cause macular edema formation. In this picture, you can see macular edema and OCT classification, focal macular edema, diffuse macular edema, and focal cystoid macular edema. And now we use intravitreal injection, anti-VEGF drugs, for example, aflibercept, and we treat macular edema. And if we see proliferative diabetic retinopathy and see neovascular vessels, we have two ways: retinal laser coagulation and anti-VEGF treatment, intravitreal injection, anti-VEGF drugs, and sometimes combined anti-VEGF treatment and retinal laser coagulation. And what about vitreous? Hyperglycemia and then cause type 2 collagen cross-linking, and we can see another change. We can see proliferative diabetic retinopathy vessels loop formation with traction, and growth of fibrosis tissue around the new walk of newly formation with vessels, and development of fibroglial proliferation detachment and formation of tractional retinal detachment. And the next step, we have vitreoretinal interface fusion in proliferative diabetic vitreoretinopathy. And we use now Kroll classification of PDVR. And you can see step-by-step changes of vitreous and retina. Now, my investigation, it's vitreocontrastography. The vitreous visualization technology discovered normal vitreous anatomy in experiment and pathological changes during surgery with special using vitreocontrast suspension. And we see vitreal layer, cisterns, and structures of vitreous. And I would like to show you the surgery. The first step, we remove hemophthalm, and then we contrast in cortex layer, and the retina was not changed without some traction, but we see a zone of ischemia, and this layer in all cases was in the central localization corresponding to exudation and ischemia zone. This is the first stage, is first A1. When we apply vitreocontrast on the case of the next stage of vitreoretinopathy, we see vitreous body structures, and layers are formed by vitreous schisis zone. On the retina surface, vitreous body layer formed fixed to the retina, and sometimes causes to retina detachment. And in these cases, you can see remove the vitreous on the retina, and vitreous surface contrasting in the central zone and strongly fixed to ILM in the macular area. And the next stage, B, you can see arterial vitreous and vitreal structure native, but in the retina you can see vitreouschisis zone and retina detachment. Retina detachment is 1.7 or 2.2 millimeter observed. And we can see normal retina on the periphery. In the central part, you can see scar and proliferative tissue. And in the operative, we can remove all scar and proliferative tissue and need to do better on the retina. We apply special dye and contrast lay by lay, and step by step we remove vitreous layers. And the next stage, you can see preserved cisterns in the central part of the vitreous, but we see membrane fibrosis and traction retinal detachment. After contrasting thin cortex layer, we start to membrane removing, and our goal was to go to the ILM and retina, and we tried to separate full fibrosis tissue. Step by step, tissue was dissection. The time of the separation 1 or 2, sometimes 3 hours. And step by step, we need to remove all tissue, and our goal to do then retina was attached. And with the new method, we see new layers. We make difference and another dye to contrast, and our vitro contrast dye, and new layers described and contrasted. And you can see on the retina the ischemic zone was consist with next changes of the vitreous and next changes of the retina. And a new study added in our classification. We change Kroll classification. And some cases before surgery and fall after surgery. Before surgery and after surgery and after anti-VEGF drug treatment. You can see before surgery, gemophthalm, and changes the retina detachment, and after surgery you can see good state of retina. And after anti-VEGF intravitreal drug, you can see not see macular edema. And the next case before and after surgery. Vitreocontrastography method provide new fundamental approach to clinical diagnostic investigation based of developed anatomic clinical things and characterized principal advance in the comparison with traditional PDVR classification. I want to say that diabetes is one of the main causes of the bleedings in the many countries, and also of several loss of the vision in the working population. Diabetic retinopathy is a social, clinical, and economical problem in primary importance. And patients with diabetic, you can cite dual follow-up by endocrinologist and ophthalmologist. Thank you for your attention. Thank you.
Thank you so much, Ms. Natalia. The presentation stood out exceptional, impressing the audience with the informative content and engaging debate.
Diabetes. Let me focus. It's about diabetes. I will touch base very shortly about also hypo beyond diabetes. So moving to the next slide, I will just make a short introduction of myself. I am MD, I am endocrinologist, mainly focused on diabetes. I'm Armenian by background, born in Georgia, studied in Russia, Switzerland, Germany. And currently I'm working in Basel, in Switzerland. My previous work was in Eli Lilly, head of diabetes, and also the very last, I was head of global medical affairs and emerging market in Ascensia diabetes care. So it's just a map showing you that I was like working across the region. So what for today, I'd like to touch base, what is hypo and what is the problem size of the hypo in terms of health outcomes, also financial one. Also give you the definition of the hypo, what is officially threshold for the hypo in different levels. Also will touch base with you diagnostic tool for glucose measurement in our body, and some challenges for detection of hypo related to accuracy aspects. Very last, I will show you which patient would need more accurate tool for hypoglycemia detection. So what about hypo? Hypo in diabetes is a very common problem. If you see what I've written below, but I'm not touching, the slides will be available for everybody. It's about 42 events per year. And mainly we know that this is hypo very common for type 1 diabetes. However, there is also type 2 diabetes patients who are suffering profile, where many of them are recognized. And of course, it depends on their comorbidity, on the age, complication, and also if you detect this hypo. It has significant clinical contribution. Why? Because we know this from record study, ECHO study, and also from other studies, this is directly correlated with acute cardiovascular disease. One of them is myocardial infarction, and also there will be also some implication, as previous speaker already touched base, about retinopathy and loss of vision. But it's also important, particularly because we are all living in society and somebody has to pay for our health, it has significant economic implications. It's not only about direct costs, hospitalization, also treated, but this major part is also about indirect costs, because it's loss of productivity and also the recovery and also deteriorated quality of life. Moving forward, one of my former colleagues, Neil Helford, she was chairman of Dutch Association of the Physician. She was assessing this, and she was, and it is a quote, that it takes about 50 minutes to return to normal functioning following on non-severe hypo. And let me focus, non-severe hypo, with negative feeling experienced by patient up to and in average 5 hours. Following the nocturnal non-severe, which is much more severe in the perception of hypo by patient, functionality was diminished even more, about 80 minutes. And negative feeling experienced by patient was persisted for about 12 hours. So we see the implication not only on the economic, not also on health outcome, but also on the patient side, on his quality of life. On my next slide, you see that patients feel major hypo also equally as they are developing serious chronic complication. The study was done years ago, but still valid. You see that kidney complication is even perceived or even is assessed less than even the major hypo whenever patient asks what you're afraid more. Then next slide show you economic implication of hypo. The major objective here is, yes, we are very good with our treatment, whatever we're developing in diabetes, and the new drugs as well, not talking today about, you see that HbA1c is dropping down. However, the rate of hypo is still very high. The study was done within the decade, and you see that from 1999 to 2011, we're not so successful really to tackling the hypo. So moving on to the next topic, what is a hypo, how we can classify the hypo, in particular why we needed this, because it's all about assessing the hypo, not only like with patient care individual level, but also in clinical work, in clinical trial. You should be very clear when you say it's hypo and which hypo it is. So this is what you see on the slides. This is current guidelines, which is consensus done by ADA and ESD. When they define 3 levels, but again, let me focus, is done based on BGM, on blood glucose monitoring. And level 1 is non-severe hypo. For some region who are operating in milligram is between 70 and 54. If the region is in millimole, you see also in the bricks also here, the hypo is in the range between 3 and 3.9. And it does not matter does patient experience symptoms or not. If he measures and blood glucose falls within the range, this means non-severe hypo. Significant hypo level 2, whenever blood glucose is detected, blood glucose below 54 milligram per deciliter. And of course, it indicates this is significant, which requires immediate attention or help. Level 3, which is crucial now to understand, it's severe, which means you do not need to need any digits. Why? Because if you see there is unconsciousness, you see that patient is confused and it cannot help itself, it does not mean that you have this level or not. So the only one thing that is requiring external assistance for recovery, whenever you give glucose or glucagon, it's already shows that this is level 3. Again, it's based on blood glucose monitoring. And of course, all depends if you measure by blood glucose monitoring device, whether it's accurate or not. Now, moving this, let me, as I mentioned blood glucose, you will ask me, okay, how we can measure glucose? So there's various technology available right now. You know that we can measure glucose in capillary blood, which is also right upper corner. We can measure also blood in arterial blood, which is usually very common in intensive care, measuring in venous blood, and measuring interstitial tissue. So I'm right now not talking about the modern technology, whatever they are proposing about measuring through subcutaneous and whatever technology they are promoting now. However, the very important to understand that yes, we have glucose everywhere, in cell, in blood compartment. However, the concentrations of glucose are different. So the point is now that arterial blood glucose concentration is approximately very, very closely to capillary blood, but measuring arterial blood glucose is more, how to say it, but more assurable and less dependent on interferences. That's why intensive care, but we have severe patients. You should not measure capillary blood. Why? Because when you have hypotension, a lot of other medication and whatsoever happening is damaging microcirculation, capillary blood glucose measure will be unreliable. That's why in intensive care is gold standard measuring glucose only in arterial blood. The second point is that if somebody is measuring like a capillary blood and then comparing with the venous blood is entirely incorrect. Why? Because in fasting state, glucose concentration of venous blood is perhaps not significantly different. However, in postprandial state, capillary blood is slightly higher. Why? Because the glucose is extracted from the blood in postprandial after meal by tissue. So capillary venous blood comparing and measuring at the same time is highly inaccurate. So I will discourage you whenever patient coming to your lab and coming for assessment, and you're trying to understand whether his meter is reliable or what is his blood glucose, please use the same compartment. It should be either capillary in both by your lab and by patient, by self-measurement device, or it should be venous, but not across of them. So here, I just put everything together for you, showing all these different diagnostic tools for measuring of glucose and how the main purposes for them today. So we need venous blood. Why? Because it's for testing for the measurement of glucose, for diagnosis of diabetes, and usually done by lab personnel, which is understandable. We're not asking our patient to take venous blood. Capillary blood is main source for self-management of diabetes. You are very familiar with a lot of devices, and this is blood glucose measurement devices. There are plenty of them worldwide. And of course, it's easy for patient to prick the finger and measure it. However, I'm not touching this about the difference between them. It's only about principle, capillary blood. Interstitial tissue, this is a main source for CGM. And you know, this is one of the major and fast-growing technology, which is also used for self-management of diabetes. This is also done by patients because it's extremely easy. It is free of pain, which is common things for capillary blood measurement. And this is major source now for making even decision-making in diabetes. And very last, arterial blood, as I thought, it's most reliable source for measurement of glucose, and this is very common for intensive. So summing up this topic, I'm trying to say is that you can't take the blood from capillary, venous, arterial, interstitial, put all of them and put an equation of them because there will be all different. So here, just the historical perspective, the very first technology for assessing glucose was, of course, SMPG, was done in early 60 years. Then we moved to CGM and FGM, which is Abbott, you know, all of them. So here I just showed you some of them, the CGM technology, which is presented by Dexcom and FreeStyle Libre, but it's not limited to, there are other CGM as well. The point is here, what I'm trying again focus on this because it's very important for your also implication with patient coming to you, that in CGM, you're measuring glucose interstitial space, which is presented here. By BGM, you're measuring in the blood. And there will be always gradient. It will be always difference between them. So whenever patient comes to you in the office and he says that, listen, I'm measuring by Abbott, it shows like about 100 milligram, but by blood it shows 80 milligram, don't blame either BGM or CGM. This is physiological reason for this. And in particular, as you know, when the blood glucose is rapidly fluctuation, and I'm coming to the point, in particular when it's very low blood glucose, because in this case, the concentration of the glucose interstitial space will be very, very low, and detection of such a glucose is challenging. So here, I'm just trying to show you that whenever you measure glucose in blood, it's like a single shot because they just measure on this moment. And this is like a principle or any photo camera. It's a single snapshot. Of course, it's limited data because you will not ask, measure, and pricking finger every single minute. The privilege of CGM is why? Because it takes every 5 or 15 minutes, depending on the technology, and it shows trends. So this is like a principal video camera. You can collect up to 288 glucose values per day, and then like calculating how the glucose curve looks like, coming down and up. And this is what is a very nice to understandable glucose variability. So it means you can't compare BGM and CGM, and you can't say that one is better than another. We are dealing with different technologies having different intention and different purpose. BGM, you need right now to understand what is the glucose. CGM, mainly you need to understand how glucose curve looks like. So very, very briefly, you know, it's not all limited to BGM and CGM. There are also coming non-invasive hypodetection, which is coming through other technology using RAM. I'm not going now in the details of this, there are plenty of. However, the key problem with this detection of the glucose is not about trend. They might be very useful to show how the glucose looks like. However, the major challenge is about accuracy. Why? Because it all depends color of the skin, also a lot of other interferences, which is the major challenges for such technology. So you can watch also this Apple Watch, you can watch a glucose watch and other things, but be aware, it's nice to have, but you can't rely on them as decision making, particularly in diabetes when you have to define insulin. So now it's coming about accuracy aspect. Why? Because when you see the digit, you take it given. You think that it's just at it is. However, it's not. Why? Because every single technology relates on data, and data relates how accurate is technology. So what is accuracy? Accuracy is closeness of agreement between the set of the measurement we get from the system and the reference value. You know what is our reference value? The reference value is always like done by gold standard side lab. So on this slide, you see that if you like to say that your system, BGM or CG, is accurate, that all results of this system should fall what is coming here low right corner. In the other scenario, it might be quite accurate having all together, but will be not precise. And you see on the left side, this is not accurate and not precise. So what about the standards? So standards for accuracy for the BGM was defined long time ago and updated, I think, in 2013, and then was implemented in the world. It's quite easy. The accuracy depends on your glucose range, and whenever is glucose range above, it's below in yellow, above 100 milligram or 5.5, then your blood glucose device should be within 15% within this range. As I said, when the glucose is low, the accuracy deteriorates every single device. The question which device is just deteriorating less than other. In this case, when it's below, this also plus 50 milligram, but not 15%. So this brings advantages using this. However, it's also depending also on the how low is the glucose. I will give you an example. Let's say if somebody has a reference value of indeed the true value is about 70 milligrams, which we know that it's like a level 1 hypoglycemia. So if you say that your device is showing is correct, compliant, plus minus 15, so his blood glucose shown by this meter would be from 55 to 85. 55 is already level 2 hypo, but 85 is normal. So this range, which was proposed by ISO, its International Standardization Organization, is still challenged for whatever you use the device, particular clinical trial, because nobody will be happy that your device go from 55 to 85 instead of showing closest to 70, which is the truth. So one of the key scenarios when you have to deal with this accuracy of the devices is, of course, in diabetes patients who are treated by insulin, because insulin dosing is directly based on the blood glucose. And whenever you measure capillary blood glucose, you will do calculation insulin dosing based on this. So accuracy is critical for hypodefinition. It's not only for BGM, it's particular for CGM, because we all know this is excellent technology, but accuracy is challenging, particularly in hypo. And also because then the CGM is calibrated BGM, and this is encouraging to calibration. So whenever you have some CGM like Libre from the embark, which you cannot calibrate, it is easy, but it brings challenge because you cannot calibrate, because it's particularly dangerous, might be if it shows that deviation of the glucose, and it's particularly dangerous, it's very high critical stage when you're dealing in artificial pancreas. So this is all study done by Mark Breton. It shows that hypodetection and also the HbA1c is directly related with the accuracy. The old time it was margin of 20%, and right now it's 50%. However, as you know, FDA is proposing also go beyond. So more stringent accuracy now proposed by FDA, particularly in insulin-treated patients, is 10% of margin. With 10% of accuracy, of course, the detection of hypo increased more than 10 times. So this is like an exercise. If your blood glucose reading or CGM reading are higher than true result, then patient will say, okay, I need more insulin. So they will be overtreated, brings to hypo. If they are lower than true, the patient will say, oh, I have hypo, I have to take some carb. So his glucose coming up, eventually coming to the hyper HbA1c. So both scenario, you will see outcomes of the incorrect readings, which brings to deterioration of the patient outcomes. This is the one of the famous case was published very widely in the journals when the Novo Nordisk was assessing one of the products that took BGMS, and they had very unusual reporting of hypo in this particular study. It was mega study worldwide, and they were wondering because they knew the product doesn't increase any hypo. So when they took this BGM, which was set up in the study and set to the was one of the key leaders, and here says this meter, he shows that meter was quite good and detecting the glucose whenever the glucose was above 100. However, this glucose was entirely inaccurate whenever glucose was below 100. By this blood glucose device was showing the glucose result, which was lower than true. That was the reason why the Novo Nordisk got a lot of over-reporting hypo. At the very end, they had to replace the blood glucose meter, set up the study again. So you can imagine what is the implication as well. Now you will ask, okay, you have standards for accuracy BGM. What about CGM? The short answer, there is no standard for CGM accuracy. We're still dealing with mean mark, as you know, however, it is average. And this is average percentage deviation reference value. It's not tailored to individual patient population. So right now is going huge discussion about this proposal, other metrics. And I think within 1 year, the metrics will be done. But this metrics for CGM also will touch base how you have to measure accuracy in CGM space. Right now, we have this just published consensus statement for continuous glucose monitoring method for clinical trials. And you see, it's all depending how long the patient is in hypo range. It's not only the value, it's also duration. And then is coming, is this hypo or not? So BGM, of course, affects CGM performance. And I said, the more accurate will be BGM, the more accurate will be CGM, if the CGM allows to be calibrated. I did my study also with Manuel Echenbach. This is a team of video fragment for When we showed just a simple thing, we took 4 BGM, we knew which BGM, but we anonymized this BGM not to be like the commercial of this. And then we just make some different patient scenarios showing, okay, if you have 4 different BGM with different accuracy threshold and a different scenario, how would it look like, what kind of decision will be deteriorated or not. So you see here on the left side, we took like a 4 BGM, A, B, C, D. Here's the names of them, and here's the production. And on the right side, you see like whatever was presented by the company, how the percentage of results are within 50 milligram or 15%. And you see they are all compliant. Why? Because this is exactly the ISO standard. You should have at least 95%. All of them were compliant. It was above 95%. However, when you go in different scenario, and here I will show you this different scenario, this, right? What? And the one of the scenario was hypodetection, another was for driving. You know, some country requires that you should measure your glucose before you drive. Next was when to start insulin during the pregnancy. And in fourth scenario, we had like a patient being on a pump and having DKA or decided on seeing the dose. And I'm going to make now here. So whenever you go on all these meters, you say they are not equal. So with some of the meters, hypodetection, particularly with the B meter, there was hypoglycemia. Why? Because it was over-reporting hypo. So the patient saw growers and true result, he will take cups and it means develop hyperglycemia. The meter C was failure to detect hypo. On meter B was no clinical impact. Going quickly, particularly in Australia and UK, the patient is required to measure glucose because if he would not measure glucose, will go travel by accident, insurer would not pay. So he has to show he measured glucose. You see that, particularly with the meter C, it was wrong result, so he could not go because it showed like below 5.5, even when it's not. I will go now to gestational diabetes on the pregnancy with diabetes. And you see also that all the meters are showing the same results. In particular, with the meter B, will be delay of insulin therapy whenever he had to start woman has to. And very quickly with the patient being compound. On the very last scenario 4B with insulin D, he will be hypo because it will be insulin overcorrection. So my major point is here is that yes, we have a lot of technology worldwide available. However, particularly dealing with different scenario in hypo, that the results shown by this, not only BGM, CGM, they are different. And this means it will bring also implication. So now comes the last point. Okay, who needs more accurate technology for hypo detection, particularly the patient who are suffering more hypo, correct? So this means, like I'll show, we have different patients, of course, that have different needs. So here, like a sum list, which is not full, but patient who has history of severe hypo, you can quickly ask patient if he was hospital, let's say, within the previous 6 months, 12 months, to hospital because he was unconscious or because he had some like a hypo, hypo unawareness. And you know, the more duration of diabetes, the more risk for patient type 1 having hypo unawareness. Of course, infants and children receiving insulin therapy. Also, patient receiving insulin therapy, particularly on intensive regimen, basal bolus. Also, don't ignore patient receiving sulfonylurea, particularly aging population. Why? Because older patients have a comorbidity, also have deterioration, and also the awareness of the hypo. And if they are using glinides or sulfonylurea, they are more at risk for hypo. So detection of the glucose, whatever technology you have, is crucial for them. Now, also the patient regular schedules from night shifts and drivers, skipped small weeks, rigorous exercise, traveling between time zones, disrupted sleep schedule. Gestational diabetes because of fluctuation of the glucose, and I said patient with comorbidity, particularly chronic kidney disease and on dialysis. So, and very last, patient with occupational risk, driving or operating this machine. So increased BGM accuracy is also needed for patients who are using CGM and Libre. Why? Because whenever they are like having like it's also in the label of them, when they are having like acute illness or having flu, or using paracetamol, high dose of paracetamol, acetaminophen, of course it's coming already as an aspect of intervention, then they need to switch or double check with BGM as well. One of the topics I was dealing in my past about detection of hyponeonates. It's very, very different topics, however, it's very common now. You have to do it. And detection and confirmation hypo in hospital setting. So what is today current statement about using CGM? Yes, you can do it. It's said, you do it. In ADA, you can see it. Also, Endocrine Society just published this guideline. However, the said you can use CGM in hospital setting, but you should be confirmed with BGM. And BGM who has label to be used as point of care, which means BGM with certification to be used in hospital, particularly in the patient who have high risk of hypo. And this is good, of course, but the warning also is that hospitalized patients can have a lot of conditions which deteriorate security of CGM. And this is what is just was discussed on DTM, also published by Guido, this review article already in print, that clinical need to understand that we can use CGM, but you should be very, very careful because your patient hospital setting can use a lot of medication, often have comorbidity with deteriorates accuracy of CGM. So don't ignore having BGM aside to double check your glucose. Here, just a snapshot, type of patient of who needs hyperdetection most accurate technology. It's newborn. The newborn, you need to detect hypos the first hours because it's vital. It's done only by BGM because you can't do CGM and wait for hours when it will be calibrated work. Then you can, of course, use a CGM, but it's for management and see where it goes. ICU patients all arterial blood. It's set in stone. It's blood and only arterial blood. Non-ICUs that can use CGM interstitial glucose curve, but you should have confirmatory BGM. And very, very special population, patient particularly with kidney disease on dialysis. It's not only having BGM, it's also having BGM with insensitive for whatever you're using, exodestrine or maltosing. And you can use CGM, but again, you have to be able to have confirmatory BGM, which is also valid for using for this patient and having not interference with isodextrin. So my very last slide, accuracy is the main feature of any single diabetes technology. Why? Because your information relies on accuracy. So accurate information requires accurate device. And then, of course, decision relies on your information. So correct decision requires accurate information. And of course, correct decision breaks the outcome. So diabetes outcomes requires correct decision. This is slide done by my colleague David Corneal from DTM. He did it in 2017, but it's still valid. So everything relies, whatever you see and whatever you're doing should be accurate. So my major point is here, we have a lot of plenty beautiful technology, but none of them fits to all patients. So one size does not fit. Thank you.
Thank you so much, ma'am. The presentation was a true master class, combining in-depth knowledge and engaging visual and confident delivery. Thank you so much.
It's my pleasure to participate today on the third global meeting of Diabetes, Obesity, and Endocrinology. I'm going to present a rare case titled Acute Exfoliative Dermatitis / erythroderma secondary to glycal azide. So first of all, I'm going to start by abstract to know the definition of erythroderma and to speak about the clinical significance of this topic. So erythroderma is a generalized term used to describe severe intense skin inflammation. The condition is also known as exfoliative dermatitis when especially associated with exfoliation. Erythroderma has many causes. I just here try to summarize the most important causes, such as adverse drug eruption, dermatitis, psoriasis, underlying systemic malignancy, and graft versus host disease, and HIV infection. And also, vast, like about 30% of erythroderma cases are idiopathic without any reason. Also, many medications can cause erythroderma, including some antibiotics, anti-epileptics medication like rifampicin, phenobarbital. Also, ACE inhibitors and sulfonamides had been described as a potential cause of erythroderma in some of the cases. So here in this case, we report a rare case of erythroderma secondary to glycal azide. As you know, glycal azide is one of the famous oral anti-diabetic medication. So the significance of this case that this presentation is very rare. So we found only one case report of glycal azide causing erythroderma in the literature. So that was actually the clinical significance of this case. So erythroderma as you know, is like considered as a medical emergency. It requires immediate diagnosis and prompt management. Therefore, early intervention should start on suspicious directly. You don't have to wait for dermatological confirmation. So because early treatment, early management will significantly reduce the mortality and morbidity of this potentially life-threatening emergency. So now I'm going to start to tell about our case. So our case, she was a 72 years old woman. She has a past medical history of poorly type 2, controlled type 2 diabetes mellitus. She has also been recently diagnosed as asthma. She's no case of rheumatoid arthritis and hypothyroidism. Uh, she was taking quite a few medications, includes empagliflozin, fixofenadine, etinercept, aspirin, atorvastatin, benzalkonium, lansoprazole, levothyroxine sodium, metformin, and phosphate and salbutamol inhalers. Uh, so she presented to the emergency department. She came with widespread extensive skin rash. It was almost all her body. She mentioned that her rash started a couple of weeks ago and it was only sparing her face. So the rash, when it appeared initially, it was on her tummy. Then it spread very quickly to involve her lower limbs, arms, and backs. And the rash was evolving initially from small spots, then it was getting bigger, uh, being more itchy, more painful lesions. So on further clarification of history with her, so she mentioned that the rash appeared one day after starting one of the new medication for her, which is called glycated, that had been prescribed by her GP uh, trying to control her blood sugar. So after the rash appeared, after a few days, she visited her GP again, who started her on some antihistamine, antifungal medication, and it showed no signs of improvement. Uh, and although that the patient, she just continued taking the glycoside, she didn't came to the hospital in a good time. And so more than that, she denied any other systemic symptoms like there was no chest pain, there was no shortness of breathing, no headache, no fever or cough, no signs of any infection at all. So in the emergency department, she was found to be afebrile. Uh, I mean, her clinical condition, it was stable. She wasn't having any signs of septic shock or any circulatory problems. Her blood pressure was relatively stable at 118 over 81. Her initial examination, I'm just going to say it now, then in the next slide, I'm going to show you the image to be like more clear picture. So the examination, it showed maculopapular erythematous scaly lesions. It was involving her trunk, chest, back, forearms, dorsum of the hands, lower limbs, palms, and soles. It was everywhere. It was just like sparing her face, and there were no any mucosal lesions detected. So the lesions were really tender and warm with excoriation marks. So I have like 12 images. We took it from different parts of our body. So this picture is showing erythematous rash on her back. This also from the right flank. This also from a different view from her back. This rash on the back as well. This on both sides. As you can see, the lesion is like really extensive. It's almost all her body of different size, different shapes, erythematous, with excoriation marks, with exfoliation. This from her tummy. Here, as you can see, there's like some clustering in her tummy, and it was a really big, large area in her tummy. This from the right side, lower part of the right leg. This from the middle part of the right leg. This from the left side. This from the right arm.
Sorry, sir. Your slides
Yes.
are not changing.
Sorry. Let me just write the other way. Was it not changing from the first slide?
Now it is visible. Thank you.
Yeah, so this I'm gonna go through it quickly. I hope it's visible now. So as I mentioned, yeah, this from her back, this from the right flank, this from the back, this from the back as well, thigh, tummy. As you can see, it was really large rash. It was involving most of her body. It's erythematous with different size and shapes and with excoriation marks. This from the right side. This from the lower part of the right leg. Right leg, left side, right arm, and forearm. I hope you have seen all the images now. Yeah. So her breast, the CRP, it was 16, so it was mildly elevated. WBCs were moderately elevated, 17.37. Neutrophils were 10.93. So all her inflammatory markers were elevated, but it wasn't very elevated. Eosinophils was 0.33, which is elevated. Her user LFT, and bone profile were all within normal limits. Her blood sugar was 13.9, which is elevated, but as we know, she's no case of poorly controlled type 2 diabetes. So also we did for her immunological screening to exclude out any autoimmune disease as a cause of her skin rash. So the rheumatic factor was elevated 73.3, which is elevated, but she's no case of rheumatoid arthritis anyway, so we thought that could be secondary to her rheumatic factor. Also, LKM and anti-smooth muscle cells and anti-mitochondrial antibodies were negative. C3 was 1.54, which is normal. C4 was also 0.2, which is normal. So majority of our autoimmune screening was unremarkable. So that by that we effectively ruled out any immunological cause of her skin rash. More than that, her chest X-ray was unremarkable. So the patient was admitted immediately from ED to the MAU, was seen by the medical team, our team. Glycoside was immediately stopped, and we start her on insulin, glargine, specifically Lantus. We give her 16 units once daily to start with. So we did for her Naranjo scale. Naranjo scale is the questionnaire type of the scale. used to define, according to certain scores, to define the probability of this of skin reaction due to any drug reaction. So there's a point like indefinite, uh, like definite, sorry, like probable or unlikely. So in this case, the Naranjo scale was 7 point, which means probable adverse drug reactions. The patient was reviewed by the dermatology team. So they examined her, they took history from her, and the diagnosis was suspected to be drug-induced acute exfoliative dermatitis slash erythroderma secondary to glycoside. So the dermatology team, they start her on Dermol 500 lotion. Uh, Dermol actually is one of the famous lotion and creams medication. It's widely used in the UK. Its contents are benzalkonium chloride and chlorhexidine, dihydrochloride plus liquid paraffin, and isopropyl myristate, produced by Derma Laboratories Limited from Hitchin in the United Kingdom. So the Dermol had been used as a soap substitute. Also, they started her on 50-50 white soft liquid paraffin, and that to act as emollient to all her body, that to be given 4 times a day. And also, they started her on topical steroids, the betamethasone valerate concentration not 0.025% ointment, and that will be given twice daily to all the red areas of her body for 5 days, then to switch once daily. So there was a debate with the dermatological team about whether to start her on topical steroids or on oral steroids, given the picture of extensive rash. And although of that, the dermatology team, they decided to give her topical steroids because her blood pressure her blood sugar was high, and we stopped the glycoside, and at the same time we start her on Lantus. So really, at that time, they wanted to avoid further worsening of her glycemic control, and because she remained clinically stable, otherwise she wasn't showing signs of like septic shock or hypovolemic shock also. So they decided to start her on topical steroids. So also as part of our further screening for urine, and so the urinalysis, it showed positive nitrate, but we are the medical team. We decided to withhold giving any antibiotics. The reason behind that because of the presence of the skin rash, we didn't want to give any further like broad-spectrum antibiotics, which had the potential of increasing her skin rash, and also considering that she denied any symptoms of UTI and the urine pressure came back negative. So looking into the whole picture, we decided it is better to withhold giving her any antibiotics, and that worked really well with her because her skin rash, it started to show improvement very quickly as she had gradual disappearance from her palms and soles lesions. That since the second day of starting the treatment. So also the dermatology team, they came on the second day. They were planning to do for her a skin biopsy, but when they noticed the significant improvement in her skin rash, so they discussed with the patient and they agreed with her that a biopsy was not really needed because her skin rash responded very well to the treatment, and also the patient herself, she wasn't keen for any kind of invasive investigation. So based on the clinical improvement, so the dermatology team, they agreed that they don't need to do biopsy. So we did for her further monitoring of her bloods after a couple of days. So her white blood cells improved from 17.37 to 10.3, and neutrophils almost normalized. It came down to 5.59. Eosinophils, it uh, it increased slightly from 0.33 to 0.47. We couldn't like link this raised eosinophils with her erythroderma, but when we looked into her previous bloods, it was almost like chronically elevated eosinophils. And we had another explanation for this raised eosinophils, as she had asthma, so that could be like associated with that elevated eosinophil. Uh, so the patient, she remained inpatient for a few days in hospital, and she continued to show improvement day after day. So we asked the monitoring team to come and see her again in the MAU. They came again, they reviewed her. They were happy about discharging her home, and they planned for betamethasone validate the topical steroid which was already on. So they planned for that to continue twice a day for a couple of weeks, then on alternate days for another couple of weeks, and then twice weekly for another couple of weeks. So the patient, she was discharged home, thankfully, and we gave her a plan in place for a follow-up at the outpatient dermatology clinic. So she had her appointment after 6 weeks, which revealed complete resolution of her skin lesions, and that was after 6 weeks, as I mentioned, in the outpatient dermatology clinic. So they advised her to continue using Dermol 500 lotion and 50/50 white soft liquid paraffin indefinitely. We called her GP. We made it clear to them that she have allergy to glycoside, just to stop that from being prescribed again to her in the future in any one of the hospitals. So that had been updated on her medical records. So that's it. Really was my case presentation. So now just I'm going to speak about the important elements in the discussion of this case. So as we mentioned earlier, erythroderma is the term used to describe intense and widespread reddening of the skin, and also it's known as exfoliative dermatitis. This name also is widely used, especially when there is exfoliation. Erythroderma is rare generally, but it can arise at any age, and it can arise in all people of all races, and it's about 3 times more common in males than in females. Most of the patients, they must have pre-existing skin disease like Venus disease, like skin cancer, like HIV, skin manifestation, or even in the patient who have organ transplantation, it can appear as part of the host versus graft interaction. Also, systemic condition known to be associated with erythroderma as well. But as I mentioned earlier, about 30% of erythroderma cases are idiopathic, no cause could be detected at all. And one of the most common causes of erythroderma is hydrochloric hypersensitivity reaction. This case, essentially. So glycoside, as you all know, it's a famous oral anti-hyperglycemic agent used mainly for the treatment of type 2 diabetes mellitus. Glycoside, it belongs to the sulfonyl urea class of insulin secretagogues. Glycoside has many side effects. The most common of it are hypoglycemia. That's why we usually avoid giving it in the old people. And also, it can cause gastrointestinal disturbance, especially in the first few days of starting it, as constipation. Some of the people, they may have nausea, epigastric upset, and heartburn. So we searched it in the literature before publishing our case. We found that glycoside with related erythroderma was found in only one case report, And we found that erythroderma is not a known side effect associated with glycoside at all. So also we reviewed the other medication that the patient take. As I mentioned earlier, she was on quite few medication, and we found no interactions with glycoside at all. So the impression of this case was acute exfoliative dermatitis slash erythroderma, and the cause proved to be secondary to glycoside. So we reviewed this case, we discussed it in the medical MDT with the dermatological MDT. We reviewed it with the history provided and with the findings in the examination. The dermatology team had been involved, and we followed the medication given to her and the options of typical steroids given to her, and the clinical course after that. So the diagnosis was proven mainly clinically. Also, the generalizability of the results made the confirmation to be difficult, especially in the absence of skin biopsy. But as we mentioned, it wasn't needed according to the discussion between the dermatology team and the patients because of the rapid improvement of her skin rash. So the generalizability made the confirmation difficult, but with the absence of other causes on one of the hands. So erythroderma was the only obvious reasons for this presentation. So my last slide really about the conclusion. So we concluded from this case report that glycoside can cause erythroderma, although in the literature review, this is a very rare side effect among other skin manifestation related to glycoside and among causes of erythroderma on the other side. So these results should be considered when prescribing glycoside in the future. And further studies will be beneficial, and it will be really needed in the future to further highlight this side effect, its incident, and if it's related to any of the triggering factors in the patient history, like her asthma, her rheumatoid arthritis, her elevated eosinophils. So it means a lot of further workup. Actually, we started on doing that. I had some contact with some of the pharmaceutical companies who wanted to investigate about other information in the case, and also treatment of erythroderma, it can be challenging sometimes. It can be very difficult to treat. They have different options of steroids orally and topically and other things, other like advanced lines by the dermatology team. But of great importance is identifying the cause to optimize the management plan. So this case had been published on Curious Journal of Medical Science, United States. The authors are myself, Saifuddin Al-Badawi, Dr. Nada Ahmed, and Dr. Muhammad Akbar. Dr. Nada Ahmed is one of the dermatology registrar, and Dr. Muhammad Akbar is one of the consultant endocrinologists. So it had been published on 25th of September 2023. I shared the link of publication on the medical journal and on PubMed site, because we mentioned there's a lot of other details like pathophysiology of glycoside, of erythroderma, mode of action of glycoside, and few other things. I couldn't mention it here for the time limit, and to try to make my presentation interesting as much as I can. Here also this is slide of the references which we used in our case. That was me really. Thank you so much.
Thank you so much, sir. Your presentation was outstanding with insightful information. The the presentation attributed to countless moments of learning,
Professor. and these are PhD, MSc, and FCS institutions as well. I belong to the Department of Sports Science and Physical Education from University of Punjab, Pakistan. As we know that, basically, the purpose of the study is to explore consequences of COVID-19 towards health syndromes, especially obesity. Obesity is concerned not only with exclusive to diet, but with stress and lack of sleep. Lockdown conditions could be cause of changes in food chain, meal timing, quantity, and the loss of attention towards daily activities. The interruptions, along with physical inactivity, affected skeletal vessels, impaired insulin resistance, which further insulated immune system, thus influenced to the lifestyle habits. A survey research is conducted on the whole population and targeted sampling method utilizing 150 male and 150 female of age 18 to 60 in Pakistan, in the major city, which is Lahore. 25 self-made questionnaires circulated through social media, received to 200 participants by different means. The cascade test is implemented on this research so that 5% outcomes for positive show significance level. The reliability is calculated through Cronbach alpha, which referred to 0.8 through SPSS. The result concluded that COVID-19 affected lifestyles and eating behavior of the people that has increased the obesity living level among male and female. Next, I'm going to proceed my presentation through different concepts. Obesity, a state of being extremely called, it was a misprint of fat is called obesity, and is called prediction of the fatness, excesses, amount, accommodation of the body fat, that is risk of health. As we know that if we have a obese person, and the most the important thing is that he's struck in number of severe diseases like diabetes, heart attack, and the most important thing is that we have to lose down the weight, and overweight is also created a problem for these things and these diseases as well. Overweight means weighting is too much. Terms means that person's weight is greater than normal and healthy weight. As up to that, we can calculate with a simple thing, which is BMI, body mass index, which is equal to the normal formula. A layman person can also calculate with a simple formula, which is weight in kgs or height in meters squared. This is a circle which we have come to know which range of BMI is going to adopt for a person to get normal conditions, just like starting from right in a proper position, we have normal, overweight, obese system, obese class, obese, underweight, overweight. These all things are going to be sorted by a specialist person or a specialist trainer who is going to help out these things, that you have to be made in proper diet or not giving any sort of activities during the 24 hours, and as well weekly and monthly. Next, I'm going to have types of diabetes. There are 4 main types of diabetes depending on the area of depositions. There are 3 types of diabetes depending on area of fat deposition. Number 1, upper body weight obesity, central obesity, lower body obesity, peripheral obesity, combination of both. Figures you have come to know that if a male person is going to change his body posture like an apple, and if a female is coming to obesity, these positions should look like and appear. Android obesity, glenoid obesity. There are 2 types of obesity. depending on the size, adult type, child type. Size of fat cells increases in child, number of fat cells increases. And these are some issues of COVID-19 pandemic in which we have different formats in athletes, healthy individuals, and high-risk individuals. Each column we have a different sort of position which are always going to show that the data we have collected from 200 participants. Post-containment competition. It's important the COVID-19 pandemic has increased numerous areas of the worldwide society since its regulation, and group activities have been no more abnormal to the valid COVID virus caused the suspension of games, conclusion of exercise, sanctioning of wellness forces, implementation on open air exercises. These elements drove soccer players to change their inactivity projects and train at home, the majority of which are not directed by medical staff or mentors. We have used Convac Alpha for going to check the consistency or reliability of the data. Statistical package for social science is used in this research, and its p-value is 0.82. These are few questionnaires which are utilized in this research, and we got results which SCK has been strongly agreed, neutral, stuff. And these are the statements with the value of chi-square and p-value. Causes of obesity, as I've told that when you're going to not get a sufficient amount of calories and it is not utilized up to the mark, it will create an unequilibrium problem, and we have gaining weight day by day, and at last we come into a obese position. Vestibular diseases, hyperthyroidism, different obesity problem is going to get at the peak point at which is different diseases, like we have a problem with thyroid, we have a problem of hyperthyroidism, and we also have a physiology of obesity. Leptin and keratin are produced separately. They control appetite through their actions on the central nervous system. In particular, there are other appetite-related hormones act at the hypothalamus, a region of the brain center of the regulation of food intake and energy expenditure. Short-term appetite control, the stomach is empty, and to stop when the stomach is stretched. Physiology of the obesity. Fat cells develop, as we have started from left to right, we have come to know one is going to increase with 3 is going to invert with a bigger one, and bigger one is going to increase with a double one. So it will increase day by day. Physiology of the obesity. See that there is a layer of fats is going to be deposited in a layer wise of a human being or person having these problems, and we have come to know the layers, which is also mentioned in the figure, in which we have come to know that the belly is going to become an apple shape or come outside. Complications of the obesity is going to check with a few things like sleep apnea, obstruction of sleep, central sleep apnea, complex sleep apnea, and these are all things which are going to lead a kind of obesity or not going to disturb of that. Obesity and cancer. According to the National Cancer Institute, obesity is associated with the hyper risk of the following obese type of cancers: breast cancers, colon rectus, endometrial, esophagus, gallbladder, kidney, pancreas, thyroid glands. Possible reasons: fat cells produce high amounts of estrogen, which may promote cancer. Obese people after have high level of insulin and insulin-like growth factors, which may also promote some kind of cancers. Fat cells produce hormones called adipokines, which may stimulate cell growth. Fat cells may have direct or indirect effects another tumor growth regulations. And these are eat healthy diet. When you are going to take a healthy diet, which is not going to come in your best, and thus is not being a factor of heart attack. Other complications. So the last I'm going to say that we have to take calories and it should be utilized according to requirement. When we spend more calories than intake, that is not creating problem for us, because due to exercises and inactivity, not properly doing exercises and inactivity at the COVID-19 level, we have a problem that the fat is going to deposit in your body and slowly and gradually it begins to obese. That's what the phase of that thing is going on, and we are, get out of this thing. But overall, this statement, thank you very much. This is all about the presentation. I'm not getting too much time for the audience and this to be as well.
Thank you so much, sir. Dr. Sajjad's passion and enthusiasm is shown through his outstanding presentation, leaving a lasting impression on audience. Thank you so much, sir.
Thank you very much, ma'am.
Few minutes for
introduction to you that I'm a PhD in sports sciences, and my major is rehabilitation. And right now I'm working with diabetes mellitus patients, and especially for the athletes which are working on different games. So today my research topic is diagnosis, treatment, and rehabilitation in Rekha curve, and cricket and baseball throwing athletes or isometric, isotonic, and diabetic exercises. And this is a structure of anatomy of the curve, in which we have supraspinatus, infraspinatus, teres major, subscapularis, humerus, and scapula. In abstract, the present stretch is aimed to diagnose, treatment, and rehabilitation of Rekha curve in national and internationally used level of baseball and cricket. We belong to 5 major cities of the Punjab in Pakistan: Lahore, Multan, Gujranwala, Faisalabad, and Sirpur, who have proper facilities along with acute and chronic Rekha curve injury. A total of 125 athletes were taken as sample size and the diagnosis based on different physical assessments, utilized to identify the level of the pre and post assessment were taken and compare the values before and after the execution of rehabilitation plan. Survey questionnaires were also used to gather the feedback of athletes to give them a rehab plan and utilized rest, fast, compression, and elevation principle. As per required, a comprehensive conditioning plan was implemented for 8 weeks as per the severity of the Rekha curve injury along with the rehabilitation. So the rehab plan included several isometric, isotonic, and aerobic exercises based on resistance exercises. The results of the condition plan were satisfactory, and all the athletes retained their strength and movement as they returned to their sports after the completion of the rehabilitation, the recovery program. The principle of specifically overloading progression, rest and restoration implemented. The keyword is science. So I've come to my presentation. I have told you that the Rekha curve for injuries, which is going to take acute and chronic injuries, and injuries to the Rekha curve is the most common source of decline and disfunction in throwing athletes across the sports, just like falling in cricket, just like volleyball, just like throwing board in baseball. And due to the demand of the sport, it has been a cut prevent both overhead and overheat athletes. The study focuses on the proper diagnosis of Rekha curve, which efficiently rehabilitation plan in sports, cricket and baseball. The rehab plan for the Rekha curve injury through proper exercise treatment using isometric, isotonic, and therapeutic exercises to help the national and international athletes to recover rapid, efficiently, effectively, and economically from the Rekha curve injury. Objective of the study to make suitable rehab plan for athletes of Rekha curve injury to regain strength and movement after Rekha curve, to strengthen the weakened muscle through rehabilitation exercise, rejoin the sports after complete recovery through isometric, acetonic, and carbon exercise. Does rehabilitation play a significant role in our recovery? Yes, you know, this is a modern era and out from sports and as well regular life as well. Rehabilitation play a major role in the recovery of athletes suffering from a rotator cuff injury. I'm going into diagnose. I'm not going to waste time for all these things, but I have to get short and precise up to the mark. So this is one of my tests which I am going to test, empty can test. The second one is drop arm test for supraspinatus. The third one is lift off test for subscapularis. The fourth one is belly press test. I have used 4 tests for diagnosis of a person having rotator cuff injury. If he has pain in moving in such kind of direction, so he is in condition of injury. Rehabilitation plan. This is the test which also can check different pain and affected range of motion of the shoulder. So positive, I have checked these people which have got complete my forms and they are short in our studies. They have positive effects, they have negative effects. And I have to work on positive effects for negative effect means it's not stuck in that kind of thing. Rehabilitation training plan is one of the major factors of the rehabilitation of the plaque condition, and a rehabilitation plan of sports injuries required extra care, high structured exercise, sports specific approach which prepared both athlete and the injured issue to required psychological and physiological demands, highest level of competition. This is 8-week rehab plan in which we have first week having for 3 days exercise, second week 2 to 3, and up to so on we have 8 weeks. In 4th and 8th week we have an unloaded week. When you are in the position of rehabilitation, so we have facing a problem, continuously training is going to get the values of muscle or power strength down. So we have to get unload after 3 or 4 weeks. So these are going to take off some pressure from the or intensity from the muscle to get recovered and get on a proper section in very soon way. Next one, rehabilitation exercises. We have isometric, cross arms, passive internal, passive external, pendulum exercise, sleeper stretch. These are few exercises. Now good results. In empty can test, we have no pain. Improve long. When we have come into post-test results, implementation, we come to know we have free from sport tests and we have increased range of motion. Number one is empty cats. We have no pain. These are results. We have increased range of motion. Top arm test, we have no improved isometric hold. Lift off, it means we are going to lift and check the muscle of the rotator cuff with the range of motion. It resulted, we have no pain and improved in static hold position. Belly press test, we have no pain. The results showed significant or optimistic results as the test conducted results with no pain and tested discussion. Kepler says that completion of the research rehabilitation of rotators independently requires fulfillment of specific criteria regarding genes, range of motion, strength, and kinetic chain rotation. That's why same the results showed by us that Kibler shows, Miller shows, and these are all results we are familiar with our findings. So in the last, I've said that we have references in which we have used from different researchers and professionals, and they are helped to collaborate much study and overlap and see and check similarities for these things. Thank you very much for your sports and so nice of you for listening. And any question from the audience, so I will be very happy to answer for that. Do you hear me, Ms. Puni?
Yes.
Is it clear now?
Diabetes tem como meta principal o desafio de treinar profissionais de saúde especializados, para que ele possa transformar a capacidade e a transformação da confiabilidade para o paciente em determinada patologia.
The continuous improvement of quality in specialized education programs with aim on the optimization of healthcare, of the care of metabolic pathologies such as obesity and diabetes, has as its main goal the challenge of training specialized health professionals in order for them to transform their training and the transmission of reliability to patients in view of their pathology, either acute or chronic.
As especialidades do benefício da educação especializada é treinar o conhecimento do profissional e qualificar a equipe para essa assistência de saúde, estimulando o paciente e o tratamento e sua base familiar na adaptação desse diagnóstico precoce.
The specific issues of the benefits of specialized education consist of training professional knowledge and qualify the health assistant team, stimulating patients in their treatment and the family basis in the adaptation of an early diagnosis.
Os distúrbios endócrinos, como o diabetes e a obesidade, comprometem a fisiologia humana, podendo causar diagnóstico súbito no paciente e colaborar para que eles desenvolvam um transtorno psicológico que venha comprometer sua vida social.
Endocrine disorders such as diabetes and obesity compromise human physiology and can cause sudden diagnosis in patients and collaborate so that they develop psychological disorders that can compromise their social lives.
Em março de 2022, a Organização Mundial de Saúde mostrou numa pesquisa global que 1 bilhão de pessoas no mundo são obesas e, entre elas, 39 milhões são crianças.
In March 2022, the World Health Organization shows in research that more than 1 billion people around the world are obese, including 39 million children.
A obesidade é uma comorbidade que afeta o organismo, causando descompensação cardíaca grave, hepatopatias, nefropatia e artralgia.
Obesity is a comorbidity that affects the organism, causing decompensated cardiac arrest, hepatopathy, nephropathy, and arthralgia. People with that's it.
A pessoa com sobrepeso ainda pode desenvolver doenças crônicas não transmissíveis, como diabetes tipo 2, a hipertensão, acidente vascular e várias formas de câncer.
People suffering with overweight also develop non-transmissible chronic diseases such as type 2 diabetes, high blood pressure, and various forms of cancer.
Segundo a International Diabetes Federation, as pessoas mais disponíveis ao diabetes tipo 2, elas variam entre 20 a 79 anos.
So according to the International Diabetes Federation, people who are more prone to diabetes, type 2 diabetes, are aged between 20 and 79 years old.
32,6% morrem por consequências do diabetes, com menos de 60 anos. Mensalmente são gastos $1.837 por pessoa.
32.6% of these people die as a consequence of diabetes with less than 60 years old. And monthly, actually around $1,837 are spent per people with treatment, amounting to $9,600,000 per month.
966 milhões por mês com pacientes com diabetes.
Yes, 966,000 per month, per people, per person in treatment with diabetes.
Algo ainda mais preocupante é que, por conta do diabetes gestacional, mais de 21 milhões de crianças com hipoglicemia nascem no mundo.
Something to add in this concern is that due to gestational diabetes, more than 21 million children are born with hyperglycemia in the world.
Aqui no Brasil, nós temos um aplicativo chamado DataSUS. O DataSUS é o Departamento de Informações de Saúde do Sistema Único de Saúde, que disponibiliza informações com análises objetivas da situação sanitária do Brasil, mensurando a saúde da população através da Plataforma Interligada de Saúde Pública.
In Brazil, we have a unified system. Actually, it's a data system of the Unified Health System of Brazil that makes available information which can allow objective analysis of the sanitary situation of Brazil, allowing us to measure the health status of the population through interlinked platforms of public health.
A apresentação do seu sistema de hospitalização mostrou 36.605 hospitalizações com uma variabilidade mensal por região. Isso anterior ao COVID.
And according to this data system, there were more than 36,000 hospitalizations recorded per region before the COVID-19 pandemic.
O diagnóstico de 5.464 pacientes com diabetes tipo 2
Yes,
e em agosto, E em agosto de 2022, os critérios de internamento de diagnóstico foi de 5.872 pessoas por mês.
So of these 36,000 hospitalizations recorded before the COVID-19 pandemic, 5,464 corresponded to diabetes mellitus type 2. In August 2022, this number increased to 5,872 per month.
O momento relacionado no ano pós-pandemia continuou preocupante para toda a sociedade médica. Melhor qualidade de vida do paciente.
Um minuto, vai aqui, deu problema. The main focus of the specialized professional qualification programs is the organizational strategy in health to improve the quality of life of patients.
O mapeamento epidemiológico para a identificação dos fatores de risco.
The epidemiological mapping for the identification of risk factors.
Isso reduz o nível de hospitalização e amputação e orientação desses pacientes.
thus reducing the level of hospitalization and amputation and favoring the household primary guiding of patients.
Todas as características do projeto são baseadas em dados de ações sociais, onde encontramos em triagem 16% de intercorrência glicêmica em paciente com sobrepeso.
All the characteristics of the project were based on post-pandemic social action data, where we find 16% of glycemic complications in patients with overweight or cardiopathies still not diagnosed.
Infelizmente, a doença metabólica está no estágio agudo e ainda é mais negligenciada por conta da vulnerabilidade populacional.
Unfortunately, metabolic disease in an acute stage is still neglected due to populational vulnerability.
É com base nessa exposição que qualificamos de forma intensiva, nos últimos 2 anos, profissionais de saúde como médico, enfermeiros, biomédicos, fisioterapeutas e nutricionistas.
And it's based on this scenario that we intensively qualified in the last 2 years health professionals such as doctors, nurses, biomedical professionals, physiotherapists, and nutritionists.
O diabetes é uma patologia que tem uma evolução muito rápida e silenciosa. E sua causa mais grave está sendo diagnosticada atualmente em território brasileiro. É a retinopatia diabética.
Diabetes is still, it's a pathology with a rapid evolution, a rapid and silent evolution, and it's more severe cause currently diagnosed in the Brazilian territory is diabetic retinopathy.
Ela é conhecida popularmente entre os pacientes como uma visão embaçada, e na maioria dos casos graves ela pode apresentar hemorragia ocular.
This pathology is commonly known among patients as blurred vision, and in some more severe cases, these patients show eye hemorrhage.
Eu gostaria muito de agradecer o convite de toda a equipe e parabenizar por esse maravilhoso evento, e desde já eu me coloco à disposição de todos.
I would like to thank the whole organization team for inviting me and congratulate you all for this wonderful event. I'm at your disposal.
Thank you so much, ma'am. The presentation seamlessly wove together different ideas and perspectives, providing a well-rounded and comprehensive view of the topic.
My article is called Satisfaction on the use of the FreeStyle Libre in children and young people with type 1 diabetes mellitus. Can you see this square or it's just me?
I can see blue screen.
Okay, perfect. So for this study and presentation, I have no conflict of interest. So let's start. According to the International Diabetes Federation, approximately 1 million children and adolescents younger than 20 years are estimated to have type 1 diabetes globally. And in Mexico, there are about 89,000 people with type 1 diabetes mellitus, in which 14,000 are children and adolescents. So I have to say that these numbers are equivalent to a large number of people, since in my country, there are about 126 million inhabitants. During my training as a doctor, I have always been interested in well-being of children, and I felt sorry for their suffering where they were hospitalized or if they had a diagnosis which treatment require painful procedures. And right at that time, I had a good friend who had a younger brother He was 4 years at that time and was diagnosed with type 1 diabetes mellitus. He came into the emergency room with a diabetic ketoacidosis. So after stabilization, doctors opted for the most appropriate management at home, and obviously this consisted of a strict and controlled diet, as well as the use of insulin to maintain their glycemic control. This situation overwhelmed both the family and the patient, since he was just a child who likes sweet and cake. But what they suffered the most was because of the many punctures that they needed to be performed each day for this management. It was almost impossible for the child to cry less than 6 times a day, and it made it more difficult to carry out treatment and assessment in the most appropriate way. Then I got to the pediatrics residency in 2018, where I found myself very interested in endocrinology topics. So when I had the opportunity to rotate at the Cook's Children Medical Center in Fort Worth, Texas, in the United States, I requested to be in the pediatric endocrinology department. It was a great experience, but what caught my attention the most was that all the patients that came for the control and review for type 1 diabetes mellitus was that only a few patients had in their blood glucose levels tested through punctures, since the majority had sensors that analyze it without having to obtain a blood sample. So in the appointments, they didn't look so distressed, at least not because of the punctures. This caught my attention, and that was when I contacted my friend to see how her brother was doing and to tell them about these new sensors that could make her brother's illness lighter. One of these type of sensors was the FreeStyle Libre, and it was already present in Mexico 1 year before, but they were not well known at that time. So we tried, once I returned to Mexico, to apply the sensor on the brother to see if he could improve. So he was, and he would no longer suffer the daily needles and stings. Now let's talk about a little of history, just in general. So in 1959, Claude Bernard, he was an important French physiologist who in 1959 determined glucose levels. And in 1963, in the United States, Ernie Adams invented the dextrosys. Then in 1970, Hubert Clemens developed the first glucometer, and in the 80s, 10 years later, tested strips and portable devices for measuring blood glucose began to appear. In 2014, was presented the first continuous glucose monitoring system. This was a glucose sensor technology capable of calculating the glycemia without punctures. This sensor is called the FreeStyle Libre, and as I already told you before, and it was approved by the FDA between 2017 and 2018, allowing today 45 countries in the world to use it. So this device arrived to Mexico in 2017, as I already told you. But what exactly does this device do? Well, so I'm sure that the majority of you know about the function of this monitor, but just a little reminder. The FreeStyle Libre is a device that plays subcutaneously, mostly in the arm, and it remains there for 14 days. It is used for the immediate glucose monitoring by calculating the value of glycated hemoglobin, the percentage of time in range, the TER, and also it can generate daily and monthly graphs and trends. With all this, it is possible to obtain glucose levels in real time and without the need of painful punctures. This is a very good opportunity for all the people, but it's more special for children and adolescents who are afraid of needles, because without them, they can live in peace as possible with a chronic disease. So in our study, we really wanted to know how satisfied the children and adolescents with type 1 diabetes mellitus who had the opportunity to use the FreeStyle Libre felt with it. And such dissatisfaction had not been evaluated in Mexican children. We took on the task to investigate it by asking how they feel using it in everyday aspects of their life. such the implantation, limitation of their activities, and confidence in the results for the treatment. We made a survey. This was invented by the researchers, and we made this survey to patients in a private hospital in Mexico City, just in the Department of Endocrinology, Pediatric Endocrinology. But I think it's important to emphasize that the focus of the study was mainly to assess the satisfaction of its use and not about the metabolic control they have had. This is a photo of where I present the, where I did my specialty in pediatrics, and it's a great and beautiful hospital, and I really wanted to take this opportunity to share it with you. Now, back to the article and research, I'm going to manifest about the materials and methods we used on it. This was a descriptive, prospective, cross-sectional, and observational study. And as I already said, we applied the survey to 30 patients. Were 7 to 24 years from the Department of Pediatric Endocrinology. The patients responded the questions themselves, unless they were younger than 17 years, in which case their parents or guardians were the one who responded. All surveys were carried out with a prior informed consent and anonymously, and the main selection criterion was having used the FreeStyle Libre device for a minimum period of 1 year. We excluded pregnant women while using the device in those patients who refused to participate in the study. And the surveys were conducted from June 1st, 2020 to April 30th, 2021. The patients themselves or their guardians were contacted by telephone by the researchers. To achieve our objective, we divided the survey into 5 classifications. Number 1 was about the application and permanence, talking about the physical discomfort and tolerance to the device. We asked about pain, itching, or burning in the arm. Number 2, about their daily activities, meaning the impact that the device generates on their daily lives. We asked if they could do the daily activities normally or if they avoid doing certain activities, and also if they were embarrassed using it in front of others. Number 3, about the blood glucose monitoring. We asked if it was easy to use and if they prefer it over the conventional glucometer. Number 4, about support in treatment. This includes the aspects of confidence in the use of the device. If they think that using the device is helping controlling their disease. So we wanted to know if they trusted the levels displayed by the sensor, and if that helps them to calculate also their carbohydrate consumption and understand their disease better. And number 5, about the device evaluation. We asked them to evaluate the device because we wanted to know the overall satisfaction and if they could recommend it to other patients with type 1 diabetes mellitus. The responses were requested in a Likert scale with option always or almost always, sometimes and never, except for the first and the last 2. The first classification they gave us no, mild, or moderate as answers. And in the last one, patient evaluated the device while using a 1 to 5 scale and a yes or no answer. Although our study didn't properly evaluate the quality of life, as a validated instrument was not used for this purpose, the classification of the survey that I just mentioned explored 3 dimensions of quality of life: the physical, the social, and the psychological. The first dimension, the physical, this is related to the adverse effects that arise from the use of the device, such as the presence of pain, pruritus, erythema. In the second dimension, the psychological dimension, we saw previous studies that reported a high frequency of anxiety and fear of using needles and lancets needed to measure blood glucose with a conventional glucometer. And this is very important because we're talking about children and adolescents. And if grown people, just like us, don't like needles, we can imagine that it's less pleasant for them just to use them. So this can really affect the psychological dimension. And in the third dimension, the social one, this also is very important in their stage of their lives, since it has been observed that maintaining their activities in accordance to their peers without limiting their socialization generates a feeling of well-being, which obviously is linked to a better life quality. So here are the results that were regarding personal data and sociodemographic factors. Of the 70 patients contacted to participate in the survey, 30 patients agreed to participate. The majority of them was male, and the median age was 18 years. The median age of diagnosis was 8 years, with a usage time of the device of 3 years. And the number of glucose measurements per day has a median of 15. And as survey results, to make it easy to understand, do you remember the dimensions and the 5 classifications I talked you about? Well, so here I show you my results, and I think it's important to compare my results with other articles to have a globalized and a better idea. So about the application and permanence, as you can see in the graph, the first graph, we can say that more than half of the patients had no initial pain upon placement. And in the second graph, it shows that just a few reported having itching or burning at the site of the placement. In Czech Republic in 2007, Teresa Hatznikova assessed any adverse effects occurring in 9 days after continuous glucose monitoring sensor was inserted. And they saw that in a total of 26 sensors inserted subcutaneously in gluteal or lumbar region, there were only minor local adverse such as hypersensitivity, itching, pain, redness, burning, and subcutaneous hemorrhage. And Anne Herman in 2017 and her team were the first to report cases of allergic contact dermatitis related to the use of FreeStyle Libre device attributed to acrylic acid isobornyl ester, that is an acrylate monomer used in plasticizers, coating, and ultraviolet cure inks. And also starting with a larger sample of 76 children and teenagers with type 1 diabetes mellitus, conducted in 10 European diabetes centers, 7 in the United Kingdom, 2 in the Republic of Ireland, and 1 in Germany, show that 42 of them, this is the 55%, experienced sensor insertion signs and symptoms such as bleeding, pain, induration, and bruising. Or sensors were like erythema, itching, rash, and infection, but just reported as mild and resolved without treatment. About their daily activities, in the first graph, the one that is on the left, the majority stated that they always or almost always carry out their activities normally. In the question that says, did you avoid certain activities because of the device in the graph on the top, only one patient complained that he or she feels limited. And like it's shown in the third graph, the majority didn't have any conflict when using it in front of other people. In the third classification that talks about blood glucose monitoring, 26 patients reported that they feel satisfied with the device compared to the conventional glucometer, and the majority find it always easy to use. And most of the patients trusted in the reading provided by the device because it makes it easier for them to adjust their carbohydrate consumption, just as you can see in both graphs. This is why 25 patients indicated that their hypoglycemia episodes have decreased, as we can see in this slide, that is about support in treatment, concluding that they have a better understanding of the disease, as you can see in these two graphs also. In the pie graph, 100% recommend the device to other patients. In 2017, Al-Hayek and collaboratives made a prospective study at the Diabetes Treatment Center, Prince Sultan Military Medical City in Saudi Arabia, where they registered on 47 patients aged 13 to 19 years who used conventional fingerprint method for self-testing the glucose and replace the conventional measurement with a flash glucose monitoring in each participant. Then, after 3 months, they administered the questionnaire Hypoglycemia Fear-Starved Child version and PITS Quality of Life 3.0 to each patient, and they concluded that the frequent use of flash glucose monitoring scanning reduced the frequency of hypoglycemia, glycosylated hemoglobin level, and worry, and increased the behavior and quality of life, as compared with self-testing by the conventional finger pricking method. And in the United States, in 2015, Bailey evaluated the performance and usability of the FreeStyle Libre for interstitial glucose results compared with capillary blood glucose results, and it was found that the interstitial glucose measurements were accurate compared with capillary blood glucose reference values. And as an important point to emphasize, the sensor accuracy was not affected by factors such as body mass index, type of diabetes, clinical site, insulin administration, or glycated hemoglobin levels. And finally, about the device evaluation, more than half of the patients described the FreeStyle Libre device as excellent. And as I already told you before, 100 patients, this is all of the patients, recommend its use to other patients with diabetes. In a Japanese study about the effects of the FreeStyle in mental health and satisfaction in treatment, Japanese reported improvement in these aspects, concluding that using it decreased the depression of in a patient. So Mexican children and young people reflected satisfaction and a positive experience with the use of the device, thanks to the ease of measuring their glucose without the need of for painful punctures. It also allows them to carry out their daily activities without important restrictions. It makes it easier for them to measure their glucose, trusting in the levels displayed in real time, creating a feeling of control on their disease. Likewise, they mentioned that they are not embarrassed by using it in front of other people, maintaining socialization, which is very important at this stage of their life. The limitations of the study, the most important is that, as I mentioned before, out of 70 users of the FreeStyle Libre device that we had in the endocrinology department with the characteristics that we were looking for, only 30 of them participated. Also, the study had to be done by telephone because of the COVID-19 contingency situation that made it more difficult to have an answer from the people. Another limitation is that the survey was applied to most middle-high class patients, and also that we couldn't verify the glucose measurements that the participant reported. So I recommend repeating the study with a larger number of patients with a greater variety of ages, gender, and socioeconomic status to have more globalized and reliable results. In the end, our goal was answered, and we concluded that the majority of Mexican children and young people with type 1 diabetes mellitus are satisfied with the use of FreeStyle Libre device, improving their quality of life in the physical, psychological, and social dimensions. This is the bibliography that I choose for our article. And I think that's all. Thank you very much for listening.
Thank you so much, Dr. Sandra, for a wonderful presentation. All the elements, graphics, data, and the little story about the little boy added depth to the already excellent presentation.
Thank you very much.
Thank you so much.